Are you ready?
We are getting live, sir. 2 minutes.
Yes.
लैपटॉप में थोड़ी है ना
Yes, Prerak, please start.
So very good evening, all of you from Corona Remedies. Warm welcome to all of you for the very insightful and very knowledgeable webinar in association of Maharashtra Obs and Gynec Society along with Safe Motherhood and Quality Care Committee, AMOGS, on occasion of Safe Motherhood Day with Zone 1 societies of AMOGS, which is Navi Mumbai, Thane, Palghar, and Sindhurg Nagari, from the makers of Code 3, C-Hope, and Dietro Hope. First of all, I would like to introduce all of you with our conveyors of the day with Dr. Supriya Arwari, who is a zonal coordinator of Zone 1 AMOX, Dr. Madan Kamble, who is a national coordinator, Foxy Sexual Health and STI Committee, zonal coordinator AMOX, Dr. Rachna Juju, who is a CP of Safe Motherhood and Quality Care Committee of AMOX, and Dr. Prerna Kishan, which is a national coordinator, Foxy Committee. So, a warm welcome to Dr. Supriya Anwari, who is practicing at Supreme Hospital Bhiwandi for last 20 years, who is also a
I think
Foxy
it's
adolescent.
okay. It's okay. We can move ahead.
Yeah. A warm welcome to Dr. Kamble sir, who is a zonal coordinator of AMOG Zone 4 from 2026 to 28, a chairperson of AMOG Sexual Medicine Committee
We can move
from
ahead
22
with
to
the
26.
conveners in
Yeah.
brief. Yeah, we don't need conveners to be
Yeah, no,
introduced
no,
so
no
much.
need for convener details. Everybody knows. Yeah.
Yeah.
Okay. Also, warm welcome to AMOG's office bearers, Dr. Amire Purande and Dr. Rohan, who are the president of AMOGS and honorable secretary of AMOGS. So starting the webinar with God blessings. Let me pass it on. Put it on, hold it now.
Yes. Yeah, thank you, Prerak. Very good evening to all of you. On behalf of AMOGS, along with Safe Motherhood and Quality Care Committee of AMOGS, in continuation with this Surakshit Matritva Vyakhyan Mala, on occasion of Safe Motherhood Day, I would like to welcome all the dignitaries and all the Zone 1 societies of AMOGS, that is Mumbai, Navi Mumbai, Thane, Palghar, and Sindhudurg. This is the third episode of this Surakshit Matrutva Vyakhyan Mala. We have covered Zone 6 and Zone 5 of AMOGS, and we are still going to continue with rest of the zones of Maharashtra. In this particular webinar, I would like to welcome our own AMOGS office bearers, Dashing and Dynamic President, Dr. Amay Sir, Honorary Secretary, Dr. Rohan, today's chief guest, respected Dr. Nandita ma'am, our guest of honors, Dr. Rishikesh Pai sir, Dr. Vinita Salvi madam, Dr. Sujata Dalvi madam, and Dr. Rohan Palsetkar. And along with my conveners, I welcome today's speakers, Dr. Parishit Tank sir, Dr. Uday Thanawala sir, our today's moderators for panel, Dr. Pradnya, Dr. Shreya, expert Dr. Komal Chavan madam, and all the chairpersons of all sessions, and all the esteemed panelists for this particular sessions. I also welcome all the presidents, secretaries, and all the delegates who have joined from all the AMOG societies, and particularly from Zone 1 societies. I wholeheartedly welcome, and I always appreciate and thankful to respected Dr. Amey sir, President AMOG, for giving us the opportunity to continue this CME series, and especially on this Surakshit Matrutva Mala. And I also appreciate the chairperson of the committee, Dr. Rachna, for this initiative and her efforts. Yes, Prerak, can I have the video? Dr. Supriya, over to you. Please wait. Yeah, over to Supriya.
Supriya, you need to unmute.
You want the headphones?
Respected President of AMOGS, Dr. Ramya Purandare, our chief guest, Dr. Nandita Palshetkar, past President AMOGS and Foxy, our dear guests of honor, Dr. Rishikesh Pai, Dr. Vinita Salvi, my dear teacher, Dr. Sujata Dalvi, Dr. Rohan Palshetkar, all the office bearers and members of Mumbai, Navi Mumbai, Thane, Palghar and Sindhudar Society, and on behalf of all my co-conveners, first and foremost, I would like to invite all of you for this Safe Motherhood initiative. A Safe Motherhood Day, as we all know, we had celebrated on 11th April, and this is nonetheless the Safe Motherhood Month. As we all know, safe motherhood is a right, it is not a privilege. And let me invite all of you with an open heart with this poetry कि अतिथि देव बन आप पधारे, स्वागत हो स्वीकार, द्वार हमारे आप हो आए, सहज लुटाते प्यार, साधन कम पर भाव विवल है, स्वागत हो स्वीकार, आशा है स्वीकार करेंगे भाव सुमन का हार. A warm welcome to all of you. And this is a small video, or rather a reel on safe motherhood that the Thane Society members had made, which I would like to play to start off this wonderful session on safe motherhood. Can you play it?
सिखा दे, गोदी उठा लेना माँ, आंचल से मेरा मुंह पोंछ देना, मैला सा लागे जहाँ.
Thank you. You can just stop sharing screen. So once again, a warm welcome to all our esteemed chief guests, guests of honor. And let me first and foremost invite the president of AMOGS, Dr. Amya Purandare, who is also the treasurer of Foxy, joint treasurer of Foxy, to please give his opening remarks as president of AMOGS. Let me thank him once again on behalf of all of the conveners for allowing us to, host this wonderful motherhood, safe motherhood series webinars on behalf of AMOGS on the AMOGS platform. Over to you, Dr. Amya.
Thank you, Dr. Supriya, for inviting me to speak as AMOGS president for this very important and very popular series on safe motherhood, which we have called as the Surakshit Matrutva Vyakhyan Mala. The word Vyakhyan Mala in Marathi means a series of orations, a series of lectures. But I think what it means to AMOGS is various aspects of safe motherhood are being covered through this very important and popular Vyakhyan Mala. First of all, I'd like to, it feels specially privileged to be sharing this stage with some of my mentors here today, Dr. Nandita Palshetkar, Dr. Rishikesh Pai, Dr. Vinita Salvi, Dr. Shailesh Kore, Dr. Sujata Darvi, and more importantly, to some of the societies which belong in my home zone. So it is like Maherpan for me, that is Thana, Navi Mumbai, Palghar, Sindhudurg Nagri, etc. I'm especially thankful to Madan Kamble, Supriya Arwari, and Rachna Jaju, our chairperson of the Safe Motherhood and Quality Care Committee, who have really curated this webinar. Special thanks to Dr. Prerna Keshan, who has also helped us in the ideation and the execution of this Vyakhyan Mala series. I'm sure that I'm seeing their efforts at AMOGS for the last so many years, and Prerna for your effort, enthusiasm at the level of Foxy. And I'm sure that you will be definitely value adds to Foxy in the future. And I wish you all the best for your endeavors. I'm also seeing my good friend Dr. Preeti Vyas. Dr. Preeti Vyas is also a very committed member of Mumbai Managing Committee, and I hope that Preeti also puts in the same effort when as she hopes to rise into the Foxy canvas. So all the best to you, Preeti, as well. Um, Today's theme for the Surakshit Matrutva Mala is on operative obstetrics, and we are covering three main issues. One is difficult cesarean section, where our two young brigade, that is Dr. Shreya Prabhu and Dr. Pradnya Supe, will be moderating a panel with the expert as Dr. Komal Chavan on various important tips and tricks that one will face or one may use when one faces with difficult situations at cesarean section. We have two fantastic orators today, Dr. Parikshit Tank, who will be talking on the art of forceps and what its relevance is today in modern day obstetrics, and Dr. Uday Thanawala, who will be talking about the new danger or the new serious concern, that is of placenta accreta syndrome or placenta accreta sex spectrum. So I'm sure that all the delegates who have joined in today, not just from zone 1, but across all the zones in Maharashtra and beyond, will definitely benefit from these important key issues. Once again, I'm thankful to all the member societies of Zone 1, the conveners, the coordinators, the faculty members, the eminent guests whom I feel extremely privileged to be sharing the stage with, and last but not the least, the delegates whom I think will definitely benefit and make each woman in Maharashtra who is going to undergo childbirth into a safe, a satisfying, a scientific, and a memorable experience. So, thank you once again. Welcome to all of you here this evening.
Thank you so much, Amia. And again, as the coordinator of Zone 1 AMOGS, I would like to extend a warm invitation to all the faculty members who have joined us from Mumbai, Navi Mumbai, Thane, Palghar, and Sindhudurg Nagri, all the office bearers, past presidents, and senior members. And now we are awaiting the speech of our dear beloved chief guest, Dr. Nandita Palshetkar. But before that, I'll hand over to Madan for a brief introduction to Madam.
Yes. We welcome our dearest Dr. Nandita ma'am. Everyone knows, I think, no need of introduction. She is a most loving personality of Foxy and close to my heart, and always uh, she's the fantastic person I have ever seen in Foxy. Welcome, ma'am, and over to you for your blessings.
Thank you. Can I have everybody on the screen because
Yeah, please stop screen sharing.
hi everybody.
Easiest 1 minute, madam. Easiest introduction for madam is president of all possible conceivable OB-GYN societies.
Thank you, Supriya. Thank you so much. Thank you, Madan, for that warm, really warm introduction. And I think that's the best introduction you could have given me. I think good evening, everyone. Everybody's friends here, and I'm so happy, really, that this is the program which Amay has invited me to त्याचं मराठी नेहमी वेगळंच असतं सुरक्षित मातृत्व व्याख्यानमाला. I think it's amazing and it's really good to be here, and especially I think Amay, I've seen you work with me, so definitely I know that this 2 years in AMOGS is going to be fantastic, and along with Rohan Palshetkar, who's your secretary, and thank you for mentoring him. I think it's important and great. So I want to first of all congratulate, I think first Madan, Rachna, Supriya, and Prerna for this wonderful CME. It's really nice. And, greetings to my co-guests of honors, which is Dr. Rishikesh Pai, who's here. I just saw him. Sujata Dalvi, a very dear friend, and Dr. Vinita Salvi. I think we've grown with all of us have grown together in AMOGS and in MOGS and AMOGS, and it's really fantastic. So congratulations, societies of Mumbai, Navi Mumbai, Thane, Palghar, Sindhugad, and Raigad. Thank you for this honor to be the chief guest. I think safe motherhood is, very close to my heart. In fact, I was first introduced to it when I became the president of Foxy. So it's not just a medical goal. I feel it's our social commitment also. Every mother, deserves a pregnancy that is safe, a delivery that is respectful, and a healthy future for a baby. So remember that, behind one safe delivery, a lot of people, we obstetricians are not only there, but our nurses, our, paramedical staff and everybody, neonatologists, pediatricians. I think it's a whole teamwork. And I know today is not 11th April, but this Safe Motherhood Day, I would like to really salute everybody who participates in making this journey really safe. I'm really happy because this webinar today is focusing on very practical aspects and very relevant updates. We have seen that the placenta accreta syndrome has increased because of the increase in cesarean sections. And I think all of us need to know how to deal with it practically. And of course, the cesarean and the forceps, which is a forgotten art. So we must remember that quality, it's very close to my heart. Care means more than clinical excellence. And it also means compassion, communication, dignity, and respect for every mother. I think respectful care is very important during labor. I must congratulate the entire AMOGS and all the conveners for announcing it. And I think I can see Shailesh Kore, president of AMOGS, Datta Panandikar, my friend, Rajendra Chauhan is there, Uday Thanawala, Parikshit, Preeti Vyas, Rekha Thote, Shreya Prabhu, and Pradnya Supe. I think thank you very much. And all the best to all those people who are hoping to come on the scene. And you all are dynamic people and we want you in Foxy. So all the best. I think Madan, Preeti, and who else? Everybody welcome to come into Foxy. Prerna also. I think it's fantastic that you want to participate and we want all this young energy to come. So thank you very much for inviting me here, and I'm very happy and all the best.
Yes, thank you so much, ma'am, for having you here. And we are truly grateful to have you and for your blessings also, as always. Over to you, Dr. Rachana, for further proceedings.
Good evening, everyone. We are now on the third webinar of our Safe Motherhood series, and it feels really special to us. And we really want to thank Dr. Amay Purandare, sir, President AMOGS, and Secretary Dr. Rohan Palshetkar, sir, for allowing us to continue with this journey. We are honored to have Stalwarts, Chief Guest, respected Nandita ma'am, our guest of honors, eminent speakers, and respected President and Secretaries of the Zone 1 societies. We launched this webinar on Safe Motherhood Day, but we continued it as Surakshit Matrutva Mala. So the name was modified by Amay sir, and we aspire to do it across all the 6 zones of AMOGS. We have done 2 zones earlier. This is the third one, and we aspire to do it in the remaining 3 zones. We are grateful to Supriya ma'am for steering us in zone 1, and to my co-conveners Madan sir and Prerna ma'am for being backbone of this series. we would like to welcome our guest of honor, Dr. Rishikesh Pai sir. We are very honored to have him here. He has been past president of AMOGS. Can we have CV of sir, please? A name that needs no introduction in Indian OBGY. Dr. Rishikesh Pai sir.
Hi, thanks for inviting me here. Actually, I'm in Delhi to install the chairman of the new Delhi sir, which I actually when during my presidency started in Delhi. So it's a very auspicious day for me here. So in fact, when Madan told me, I totally forgotten. But I would like to congratulate all the the four societies who have got together under the leadership of our great new AMOX president Mayor Purandare and Secretary Rohan, and then the four of you who are there who have coordinated this Dr. Madan, uh, Prerna, Supriya, and Rachna. Lovely dance, Supriya, by you. It was a really, you all have very good talent. And then, of course, I would like to also recognize the chief guest, past AMOX president, and my colleague, Dr. Nandita Palshetkar, the president of the Mumbai Society, Dr. Shailesh Kore, and of course, my very good classmate, she's my intelligent, super intelligent classmate, Vinita Sarvi. And then Datta Panandikar, our great friend, my great friend, and the Rajendra, who has done so much work in blood transfusion. We have got Rajnish also, and Sujata Dalvi, another of my classmates. I'm really today privileged. So many of my classmates are there today. Uday Thanawala, the great Uday Thanawala, who has been our. You remember, you have been Mr. Foxy also, handsome. And the other Supriya is there, Shreya Prabhu is there, Pradnya Supe is there, and Preeti, who is going to go for the election, along with Madan and the other person Raj, Prerna. So anyway, so basically, I don't want to take your time. Sorry if I missed out on anyone. I think I've taken Rajnish's name as well, but basically, I only want to tell you this that it's for us, federation is very important, and then all our Maharashtra societies are important, and more than that, our unity is very important. So, our biggest curse of Maharashtrians has been disunity. Na? We have always hated each other, and that we had over the years we have evolved ourselves and we have overcome that hatred, and that is very important. That we have to stay with each other, whatever differences are there. Ultimately, where we have to close the ranks. We should not allow our armor to be exposed in the battle. And that is very important. Initially, whatever fights you do at your local level, when it comes to the national level, all the म्हणजे सर्व ढाली आहेत ना त्या एकत्र येणं जरुरी आहे. हे दिस इज बीन अ बिग प्रॉब्लेम इन अवर स्टेट ना. फितुरी आपली बिगेस्ट प्रॉब्लेम आपला होता स्टेटचा, आणि ही फितुरी ना काढून टाकली पाहिजे अजिबात. ती फितुरी आणि अवर लेवल आपल्या इंटलेक्च्युअल लेवलला तर फितुरी नाहीच हवी. तर हे इम्पॉर्टंट आहे. बाकीचं तर सेफ मदरहुड अँड ऑल वी ऑल नो इट इज इम्पॉर्टंट. दॅट्स ऑल देअर. No one is denying it, but unity is very important. That's how our state has always been a progressive state. We are the leaders, and we should maintain our leadership by being united. Of course, it was important to be a part of our nation also. India is one nation, but at the local level, we have to be united. So that is what my advice to you is, that all the people, uh, whatever happens, at whatever cost, we will always side our people. That is our first priority. So that is very important. So thank you very much for calling me here, and wish you the very best for the seminar.
Thank you so much, sir. It is very truly said that united we stand. So thank you for gracing this webinar and guiding us. Your words inspire us. Our second guest of honor for today is Dr. Vinita Sarvi, madam. She is eminent trustee of MOGS and past honorary secretary of AMOGS. She is professor and head of unit of St. GS Medical College. She is principal investigator and officer in charge of ICMR. She's at editorial board of Lancet and Journal of Postgraduate Medicine. So as Pai sir rightly said, Madam is a very learned person. So let's hear it from ma'am. Over to you, ma'am.
One more
No, it's such
special
a pleasure.
introduction is Madam is my dear teacher. I was a
Okay.
registrar at in KEM, and it was a real honor to learn under her.
Well, y'all are doing so well that it's really lovely to interact with all of you. It's a beautiful initiative on the part of AMOGS. Thanks, Supriya. Thanks, Ameya. Thanks, Rohan. And I'm looking forward to the academics of today's evening. Thank you for having me here. Thanks.
Thank you so much, ma'am. Thank you for blessing us. And I now hand over the mic to Prerna ma'am to introduce our remaining guest of honors.
Thank you, Dr. Rachna. It is a great pleasure to have such stalwarts today in our webinar, and we are really, really honored to have you all amongst us. I take the honors to introduce our next guest of honor, Dr. Sujata Dalvi, Madam. For Sujata Dalvi, Madam, she is editor-in-chief of Jogi and the present secretary of MOGS. But for us all, Ma'am is a legendary figure when it comes to credentials, scope, impact, and relevance in the field of editorial, international repute, raising all standards of statistical information
Thanks,
and
Prerna.
reporting.
I think that should be enough. Yeah.
Thank
Thank
you,
you.
ma'am.
Thank you, Dr. Prerna, for a very kind introduction. At an outset, I would like to express my gratitude to AMOG's President, Dr. Amaya Purandare, for initiating such a good webinar on a safe motherhood and quality care. Dr. Amaya has been involved with a safe motherhood and Manyata since last so many years that this is absolutely the correct topic and the correct webinar that he has selected. Along with that, I would also like to express gratitude to all over his team for taking the initiative and very vibrant conveners of today's program, that is Dr. Madan, Dr. Rachna, Dr. Prerna, and Dr. Supriya. Two of them are already going for some future endeavor in Foxy, and my best wishes to them. I would also like to express my gratitude to Zone 1 coordinator Dr. Supriya for gathering all Zone 1 societies to have this program. Today's program is why it is very relevant. All of us practice obstetrics and gynec, and the today's topics, that is forceps updated, because people have lost the art of forceps application, and it's very relevant that they should know. Pass, of course, everybody knows with increase in C-section, so I'm not going to say much. The third thing is a panel on difficult C-section. All of us do C-section, but when there is difficulty, you should have a presence of mind and you should have some skills to tide over the crisis. This is something which you cannot be learned, but you should have a skill program on the same thing. Then only you'll able to handle the whole thing. And I'm sure people are going to learn from by attending today's webinar, and they will be able to implement in their practice. My best wishes to Dr. Preeti Vyas for her future endeavor in Foxy. And my special mention to Dr. Shailesh Kore, who's there, of course, Dr. Datta and Dr. Rajneesh Patel, and rest of the members, of course, Dr. Uday Thanawala and Dr. Parikshit Tang, who are also going to be the today's speaker. And my best wishes for today's webinar. Thank you so much.
Thank you so much, ma'am, for your blessings, and we are really honored to have you amongst us. To invite our next guest of honor, very own Dr. Rohan Palshetkar, the Young Talent Promotion Committee Foxy Chairperson and presently AMOGS Secretary, Association of Maharashtra OBGYN Society's Honorary Secretary General. And about Rohan, if I say, he's not just a friend, but a mentor, a guide, and somebody who cuts around all the noises, and he let us know what actually matters, navigating through all ethics that is revolving around medical fraternity. I welcome you, Rohan, for your words of wisdom. Rohan, are
Prerna,
you there?
yeah,
Yes.
Prerna, thank you so much. I must say that was a very kind introduction. Thank you very much. At the outset, I don't want to take too much time because I'm sure everyone wants to jump into the scientific program, which is so beautifully designed. So I want to congratulate all the conveners for doing such a fantastic scientific program on very important topics. As Sujata Madam said, the art of forceps is something that is really being lost because everyone is moving towards more different modes of delivery, I should say. Rather than that, we've heard our president of Foxy also talk about the justification of the cesarean rates. So I think it's an important topic which should not be lost, or rather, the art should not be lost. Uday Thanawala, sir, someone who has always he's been a past ICOG chair as well, and he has and his lectures are generally very on point, giving very clinical aspects. So looking forward to that. And difficulties in LSCS. We all know that every LSCS is different, and no matter what, everyone's going to face a different scenario. So it's always good to hear panel discussions on such topics because everyone has a different perspective on the same case raised. So I think the selection of topics has been fantastic. And saying that, I want to thank all the presidents and secretaries of the Zone 1 societies for collaborating with AMOGS for conducting the program. Because honestly, it's without the support of all the Maharashtra societies, these programs cannot reach to all our members. So thank you very much for being there. And obviously to all the conveners, congratulations. I've been attending all the zonal webinars, and I think you all are doing a fantastic job to make sure that we are reaching out there. Prerna, I have to thank you, as we call you an honorary Amogsian now, because you've been a part of all the zonal webinars. So thank you for being a part of this, and all the best to all the candidates who are contesting for the elections. I'm sure you all are going to do very well, make Maharashtra proud, and take your committees to the next level. Thank you very much.
Thank you, Rohan. It is indeed a real pleasure to hear from an exemplary leader of AMOGS like you. And we really look forward for more insightfulness in the future with all the endeavors that you take. And you really are a youth icon for all the Foxians and all the OBGYN people around. Thank you so much for being with us. And we now hand over to Dr. Madan for the
Yes, thank you once again, all the respected dignitaries and all the chief guests and guest of honors and all the president secretaries of all the societies for having you here and for this wonderful inauguration. And on behalf of myself and Dr. Prerna, Dr. Preeti, we would like to request you humbly to kindly nominate and kindly support in upcoming elections of Foxy, which are to be held in August 26. Thank you so much.
Madan, I would also like to, appeal on behalf of all three of you, Dr. Madan for Sexual Committee, Dr. Preeti, Dr. Prerna for YTP. Please, all of you do support. They have been working hard, tirelessly over the last several years with their particular committees, and I have witnessed their growth. So all the very best to you. And before we start the scientific session, one quick thank you to our dear esteemed faculty, Dr. Parikshit Tank and Dr. Uday Thanawala. In the first go, they gave me the heads up. They agreed to participate, and with such interesting topics. Same thing holds true for all the panelists, the moderators, and the experts. And looking forward to a really action-packed academic session. So over to the MOCs for the further, taking forward the program.
Thank you, Supriyadi. Without much ado, we will move on to our scientific program. And the first speaker will be Dr. Parikshit Tank, sir, speaker of international repute. Sir is to be there for forceps updated. And to chair this session, we have our very revered Dr. Shailesh Kore, sir, President of Mumbai Society. Dr. Bindu K.S. Madam, President of Navi Mumbai Society, and Dr. Shamita Birmole Madam, Secretary of Sindhu Digar Society. I request one of our chairpersons to kindly introduce our very revered Dr. Parikshit Tank, sir.
Good evening, everybody. I think before I start, I must thank Dr. Amaya and Dr. Rohan for inviting us, and Supriya, Madan, Rachna, and Prerna. It is actually a privilege to share a platform with Nandita, Rishikesh, Vinita Madam, and Sujata, with stalwart speakers like Parikshit, Uday, and the good panel. So I request my co-chairperson, Dr. Bindu, to introduce Dr. Parikshit. Dr. Bindu?
Yeah, thank you very much for inviting me as a chairperson to for this
Bindu,
session.
Madam, please unmute yourself.
Yeah, ma'am, I have unmuted.
Or you can just increase your volume.
Yeah, one sec. Yeah, am I audible?
Yes, very much.
Yeah. Thank you for inviting me to chair this session on forceps updated, because forceps as an art is a fundamental skill that each obstetrician, I believe that every obstetrician should know this, but somehow it has lost its charm. So Dr. Parishit Tank he is here to update us on what is the role of forceps in modern obstetrics. He is a consultant at Ashwini Pluro Clinic and Center for Assisted Reproduction, Mumbai. He's a consultant at Surya Sinova's Jupiter Hospitals. He's a consultant for assisted reproduction at 20 centers across India, and he holds the affiliation of Deputy Secretary General Foxy, Chairperson of Safe Motherhood Committee Foxy from 2014 to 17. He has been the clinical secretary of AMOGS Society, examiner for MRCOG Part 3, a very accomplished postgraduate teacher and examiner, College of Physicians and Surgeons of Mumbai. He has got various awards and publications to his credit. To name a few are Dr. Bhaskar Rao Gold Medal for first place at DNB, Dr. Kamini Rao Yuva Foxy Orator 2011 to 12, and more than 100 peer-reviewed publications in index journals, CME publications, and textbooks. Over to you, sir, to enlighten us on this very much, required session.
Good evening. It's great to be a part of this webinar. And my special thanks to Dr. Amay Purandare as the AMOGS president, for inviting me, Dr. Rohan Palshetkar, and all the wonderful people who are here today. All celebrities are here. Great to see all of you. My thanks to the chairpersons, especially Dr. Kore, President MOGS, Dr. Bindu. Thank you for introducing me. And I'll just start sharing my slides now. And I'll put it on full screen. Okay, I hope that's all right. Are my slides visible? Am I audible?
Yes, sir. Yes, sir.
Okay, super, super. So the topic for the day is forceps delivery. I thought I'll add another layer to it and talk about it being an essential skill and how we can enhance safety in our practice. So why is it an essential skill? Because it has an established place in obstetric practice. If you know how to do a forceps delivery, you can potentially avoid difficult cesareans when it's, full dilatation, the head is low. You can overall reduce your cesarean section rates. And in certain sort of emergency situations, say for example, a sustained bradycardia at full dilatation or a cord prolapse, or some such situation where a delivery is needed very quickly, if you can apply a forceps successfully, you will save that baby from hypoxia. But what are we worried about? We are worried about maternal complications. And the one which really scares most obstetricians is injury to the genital tract, which can be from the fundus to the anal sphincter. Anything and everything can bleed and tear. So you can get uterine ruptures, broad ligament hematomas, cervical or fornicial tears, vaginal hematomas from tears and paraurethral injuries, and of course, anal sphincter injury. This can result in bleeding, the need for more interventions, blood transfusions, and long-term sequelae, including sepsis, wound disruptions, pain, so on and so forth. And what that ultimately does cause, not only in women, but also amongst obstetricians, is tocophobia. We just refuse to think about labor as a reasonable option to deliver somebody. And this tocophobia is real, not only for patients, but also for obstetricians, because, if you're suturing some hematoma at 3 o'clock in the morning after applying a forceps, that's not going to be your favorite instrument anytime soon. We are also concerned about fetal complications, mainly injuries and the chance of lacerations, need for NICU, sepsis, so on and so forth. And as a result of this, forceps is increasingly what we call an art which is being forgotten. It's because of the maternal perception that there'll be injury, not only to herself, but also to the child. We are concerned about medical legal implications. We agree that C-sections are as safe as they can be today as compared to any other point of time in history. And all this has resulted in falling rates of forceps, even as compared to vacuum, amongst modern obstetricians. And of course, training is itself on a decline. So we get into this, what I call a vicious circle of forgetting an art. First, there is fear. So you want to avoid doing that particular thing. The moment you start avoiding doing a particular clinical action, your level of competence, your level of skill reduces. And when you need to do that in a particular situation, you're more likely to have an undesirable outcome. That undesirable outcome is going to result in more worries, concern, and fear. And this whole cycle just keeps going on and on. So the art of forceps application really is with this Latin proverb, non vi sed art, that is, not with force, but with skill. How do we enhance safety in these circumstances? The idea is to become fearless. I don't mean careless. I mean reduce your fear by practicing according to protocols and having medical and medico-legal safeguards in place. Training. This is another very important aspect of enhancing safety, and this can be achieved by simulators. These are very lifelike nowadays. I mean, you get very good mannequins and fetal heads, which you can really practice on. For something like forceps delivery, I would really strongly recommend having a mentor who will handhold you in the first few times that you need to relearn applying a forceps. We all have done it as postgraduates, but it's just that in private practice, sometimes the habit has worn off and you need to relearn this skill. And of course, by attending workshops, attending seminars, conferences, so on and so forth, which we all are doing at the moment. So if we look at the three main, pillars of safety enhancement, you want to practice by protocol. That is, you establish an indication and make sure that there are no contraindications. Have medical safeguards in place. That is, you understand that there is something called a concept of trial in terms of an instrumental vaginal delivery. You make sure that you choose the right instrument for the right occasion, avoid common pitfalls, and there is a concept of parallelism, which I will demonstrate a little later in the talk. Your medico-legal safeguards are the same for any surgical procedure: counseling, consent, documentation. These are important for operative vaginal deliveries and forceps as well. So when we look at indications, the purely prophylactic forceps, which was advocated by Joseph Bolivar Dilly from Chicago in the 1960s, is today not very relevant at all. Yes, we do use prophylactic forceps, but when there is a medical reason to not allow the second stage of labor to be prolonged, as in you want to avoid maternal exhaustion or exertion in a woman who has a heart condition or preeclampsia, neurological situations, or you want to protect the fetal head in a SGA birth. If there is prolonged second stage, in a nully, this is supposed to be 2 hours without regional anesthesia and 3 hours with regional analgesia. In a multi, it's 1 hour less. But practically speaking, I think this is probably too long. Most obstetricians that I have spoken to and interacted with call it a day at somewhere between 60 and 90 minutes. Maternal exhaustion is a subjective evaluation. And of course, you can apply forceps for abnormal fetal status, which I mentioned to earlier, thick meconium, abnormal heart rate patterns, cord prolapse, so on and so forth. And then there are, of course, some special situations like a mid cavity rotation after coming head of a breech or forceps at cesarean, which I'll not talk about in today's talk. So, in current practice, the indications are that you have to have a medically sound reason to apply an instrument. And the standard indication of needing to expedite delivery for maternal or fetal well being is still very valid. What type of instrument to use? Well, really, you would only think of avoiding the ventouse at preterm gestations. Otherwise, whatever one is comfortable. The contraindications for forceps, if there's definitely a cephalopelvic disproportion, fetal malpresentations, absolute ones are, of course, the brow and a face with a mento posterior. But even a face with a mento anterior is supposed to be a relative contraindication, but for all practical purposes, it's not on. If the station is very high, the cervix is not fully dilated, or there are certain disorders of fetal structure or coagulation, those are all contraindications to instrumental deliveries. Now, where do you draw the line? Most obstetricians have not seen, and thankfully so, a high forceps. That is something that has been abandoned quite a while ago. But there are still some practitioners who practice mid cavity forceps. And this is still okay. This is a part of obstetric practice. I won't say routine obstetric practice, but yes, it can still be considered a part of practice. But most obstetricians should be well versed with application at low stations and definitely at outlet levels. One question that I often ponder and have been asked is that should there be a trial of an instrumental vaginal delivery? What is it? It's an attempt at forceps delivery, knowing fully well that this might fail. The important thing is to be prepared to shift to a C-section as and when needed and to know when to stop. I always think of every instrumental delivery as a trial of instrumental delivery. There's nothing like being over prepared when it comes to obstetrics. The functions of an instrument, if we were to compare between the forceps and the ventouse, the biggest difference between the two, the forceps and the ventouse, is in terms of traction and compression. The forceps can apply traction and can apply compression to a much greater degree than the ventouse. The forceps, especially the parallel forceps, can also correct asynclitism. And that brings me to this very important aspect, that why do instrumental deliveries fail? The obvious reasons are all, very well documented. Cephalopelvic disproportion, high station, cervix not fully dilated. But we sometimes don't appreciate the contribution to things like malrotation, deflection, and asynclitism to this problem. Now, what exactly is this asynclitism? Let's look at that as a concept, and what is the meaning of synclitism and asynclitism. This is a fetus who is in labor with a cephalic presentation. As labor progresses, there is going to be descent and promotion of flexion. Here, it is depicted that the sagittal suture is exactly midway between the pubic symphysis anteriorly and the sacral promontory posteriorly. However, this rarely ever happens in real life. Usually, the sagittal suture is tilted anteriorly or it may be tilted posteriorly, and this is called asynclitism. Asynclitism is a natural mechanism by which the fetus navigates the pelvic canal. However, an excess of it is a problem because that will result in a situation where the baby cannot negotiate through the pelvic canal at all. So, how does parallelism of forceps help to correct this? Let's understand this concept on a fetal head and the application of forceps. Now, if you can see here, the occiput is between left occipital transverse and LOA, and the sagittal suture is more posterior. So you apply the parallel forceps blades, and what you will see is that the blades don't lock at exactly the same level. There's a gap, there's a difference at the level of where the blades lock. But as the fetal head comes down, it rotates and the blades come to the same level. So that's how the asyncretism gets corrected. And this correction results in the least amount of injury to the pelvis and the baby. So I'll just show you a typical parallel forceps application. Clinical situation is pretty standard. I mean, this was a preemie post dates induced with prostaglandins. She opted for epidural analgesia. She's been fully dilated for 120 minutes, been pushing actively since 45. She's exhausted. The head is not palpable. FHS is good. Station is somewhere between +1 and +2. So first you do the assessment. Make sure that the cervix is fully dilated. There are no contraindications. Now, one tip, hypoflex the thighs on the abdomen. This opens up the pelvis just that little half to 1 centimeter. Now you introduce the left blade on the left side of the pelvis. Remember that this is parallel forceps, not a crossed one. That blade is held by the assistant. I introduce the other blade, slide it in carefully, and as you'll observe here too, the forceps blades don't lock at the same level, but there is a lock. Now I give a tentative pull just to check that yes, there is a descent of the head, and that assures me that the delivery will occur. It's only at this point that I give an episiotomy. Till that point, I can very comfortably introduce my instrument into the vaginal tract and not cause any trauma. For some reasons, if my blades don't lock or if there's no give sensation on that trial pull, I can just abandon this and go up and do a C-section. Easier said than done, but yet that option remains without causing any injury. So having given an adequate episiotomy, I'm going to ask the assistant to support the perineum, and I'm going to give traction along the curve of Caris. And small rotatory and rocking movements are needed sometimes in order to just deliver the baby out. And this baby, as you can see, is born face to pubes with a cord around the neck. And nice lusty cry. So that's the beauty of the parallel forceps. Even at a higher station, it looks effortless, doesn't cause much injury to the maternal pelvis. And these are, of course, the elements that you have to document. Why did you do what you did? What did you do? And what happened? So these important things should be mentioned in the case paper. How do we train? How do we get better? Mannequin-based training, that's what you need. I would really encourage all medical college teachers who are attending and are a part of the audience today. Please encourage your mid-level guys, the tutors, the senior registrars, the lecturers to do this, demonstrate it to the residents. Maybe the first few times you'll need to make the effort of supervising them. But this is going to be an invaluable experience which postgraduates will gain. Thank you all very much for your kind attention.
Thank you so much, sir. That was indeed an elaborate, informative, and quite an enlightening deliberation on forceps. And your perspective has definitely given
I can see
so much,
Dr.
so much
Ganpat
more
Sawant. Hi, sir.
clarity.
Thank
Hi,
you.
hi.
Thank you as always for lending me that
Arre.
skull and fetal head.
So much clarity on the subject, sir. Over to the chairpersons for their expert inputs. Shailesh, sir.
Thank you, Parikshit, for this really practical lecture on forceps. Really, as he rightly said, it's been a few years, maybe more than 10, 15 years. This the art of forceps delivery has gone down, and this is one reason for this is mainly the inadequate training. Because when we were resident, the percentage of forceps delivery used to at least 8 to 10%, and now it's less than 1%. So it's been a problem with the training, and I think at mid level or a lecturer who is actually doing emergencies with the resident doctor should be more proactive in training junior residents, so that when they become senior, otherwise it becomes a more of a vicious cycle. Because when you are a resident, you have not adequate experience about the forceps. So when they become a senior resident or a lecturer or you are higher cadre, because they themselves don't know about the application of forceps, they are not confident, they don't teach the juniors. So that should be kept in mind. Very good. And I request the other chairperson to give some expert comment before we conclude. Dr. Bindu and
Thank you, Dr. Parishit, for that wonderful lecture, as always. And I feel that, as Dr. Kore was telling, we should be training the juniors, so that many of them, when we take them for exam, they haven't even seen the forceps. So that is again, so we should be, and now with simulators around, it's very easy to train them also. So I think every college, medical college or institution should have simulation based techniques to teach them, so that they understand what exactly. And sometimes it really helps before even you prepare for cesarean section. So we have all been trained in the art of forceps, so we know that sometimes getting up the patient for the anesthesia and going on that, that may, this forceps delivery may save time. Thank you, sir, for that wonderful lecture.
Thank you, sir.
Parikshit, if I can add one thing,
Of
I
course.
use routinely forceps for delivering the fetal head at the cesarean section. And
Yes.
believe me, it is such a relief to do it, because the anesthetist is not,
Yeah.
thumping the patient's abdomen and giving
Completely
her
agree
fundal
with you.
pressure. For floating heads, it's excellent. For premature heads, it's
Yeah.
excellent. So remember the use of forceps during the cesarean section, so you keep the art of forceps alive anyway.
Thank you so much, sir.
Definitely. Thank you.
Wonderful
Thank
lecture, Parikshit. I
Thank
enjoyed it
you.
thoroughly.
Thanks.
Thank you.
Thank you.
Do we have any other chairperson to conclude the session? If not, we can go ahead, and I extend my earnest gratitude to our esteemed speaker, Parikshit Teng sir, and all our revered chairpersons for a very insightful session. For proceeding on to a further scientific session, I hand it over to our co-convener, Dr. Rachna and Dr. Madan. Kindly do the honors.
thank you.
Thank you, Prerna. Thank you, Parikshit sir, for the wonderful talk. We will move on to second session now.
Thank you,
For
Madan.
this,
Thank you.
yes. Thank you, sir. For this session, I welcome the esteemed chairpersons, Dr. Rekha Thote ma'am, who is the president of Thane OBGY Society, Dr. Rajendra Chauhan sir, president of Palghar Society, and Dr. Sanjay Nigudkar sir, president of Sindhudurg Nagari Society. I welcome the chairpersons. And over to you, Chauhan sir. May I request you to introduce our speaker, Dr. Uday Thanawala sir.
Okay. First of all, let me thank Dr. Amay and Rohan for calling us for this session, and also to all the dignitaries, Madan sir and Supriya and all, for including us, our society. And it is great privilege to introduce Dr. Uday Thanawala, because he is very eminent personality, and he is a consultant OBGY from Navi Mumbai, chairman of College of Obstetric Gynec Society,
in 21-22, Vice President Foxy, India in 2015, Treasurer PCOS Society of India, Chairperson Medical Disorder of Pregnancy Committee of Foxy in 2006-2008, uh, Founder, Secretary, and past President of Navi Mumbai Society OBGY, Joint Secretary Foxy 2005, and he's a gold medal. He got gold medal in
Thank you,
FCPS
Rajendra.
exam. Uh,
I think it's okay. It's very ancient now.
yes, sir. We welcome you,
So
sir.
let it be.
Yeah,
Thank you so much for
we
that
welcome you, sir.
introduction.
Thank you, sir. Thank you. We welcome you, sir. Thank you. Please stand.
So it was wonderful to get invited to this webinar which AMOGS has done. Thank you so much, Rohan and Amiya, for this opportunity, and wonderful workers you have with you, with Supriya there and Prerna there and Madan there with doing a great job. So, so many people here, and I'm going to share my screen now because the topic which is there is about the placenta accreta spectrum. Is my screen visible to all? And that's the full screen. Is it okay? Audible, the audio and the...
Yes, sir. Visible.
So why does the placenta accreta spectrum matter? We know that the reason for this placenta accreta is because of the rising cesarean section rates, and that is why the incidence has risen. I'm sure Vinita will remember. And when we were co-house surgeons, we didn't see so many cases or hardly any cases of a very adherent placenta. It was a rarity to see that. A placenta accreta spectrum leads to a high maternal morbidity. There's massive transfusion required. There is ICU stay required, and a lot of things are there when this happens. And of course, we all obstetricians are at a high litigation risk. So we all know that there is the normal placenta accreta, increta, and percreta, but a very nice saying which I just heard last week when uh, Dr. Amit took the lecture in one of the conference, and he says, Shakespeare says a rose is a rose is a rose. Whatever name you give it, it will still be a rose, it will spell the same. Similarly, for the past spectrum, whatever adherency it is there, it will just remain the same. It will make you land up in the same problem of hemorrhage and all sorts of problems whenever there is a placenta accreta spectrum, whether it is increta or percreta. So basically, it may affect up to 1 in 533 pregnancies. The etiologies is that the defect of the endometrial myometrial interface leads to a failure of normal decentralization in the area of uterine scar, which allows abnormally deep placental anchoring villi and trophoblastic infiltration. In a systemic review, the rate of placenta accreta spectrum increased from 0.3% in women with one previous cesarean to 6.7% in women with 5 or more cesarean deliveries. So cesarean section is one of the causative risk factors for placenta accreta. But placenta previa is another significant risk factor because placenta accreta spectrum occurs in 3% of women diagnosed with placenta previa. So I'll take you through some clinical situations which I handled, and it'll give us an insight on how to manage these cases. There was a 38-year-old Gravida 2 Para 1 previous LSCS who came with a 38 weeks in the evening OPD for elective LSCS. On sonography, it was an anterior low-lying placenta reaching till the os, not accreta. Patient demanded an LSCS according to Murat at 9 p.m. in the night next day. When I did a scan on her, I found this sort of a picture. I thought there's a loss of retroplacental clear zone. There were placental lacunae seen, and that is why I was very worried that this placenta previa is a placenta previa, and there are areas which are probably adherent to the low uterine segment. So I counseled her as a case of accreta. And I told her that LSCS will not be done in the night, it will be done in the morning. Even if it's only a placenta previa, as the radiologist has reported, it can cause massive hemorrhage and which may require blood transfusion. extra surgical procedures like compression sutures, internal iliac ligation. At times, even this fails to control hemorrhage, and removal of the uterus may be required as a life-saving measure. So the option of doing in a tertiary center also was discussed with the patient. I said, you want to do it in a bigger hospital, we will do it there. But the patient was not very keen and said, no, no, we'll do it at your place. But all this thing was explained to the patient, and the patient sort of realized that maybe this is not a very good idea to do it in the middle of the night. So they agreed for a planned elective cesarean section. We prepared and made sure that blood and blood products are available in the blood bank, and somebody was there to transport it. We roped in a senior assistant in case internal iliac ligation and a hysterectomy is needed, and I called two anesthetists. So that was the preparation which I did for the case. At surgery, it was a case of placenta previa. We had to cut through the placenta to deliver the baby. Placenta mostly previa, but partial placental tissue totally adherent. Excessive bleeding after removing from the placental bed. Multiple sutures were taken on the uterine bed, and uterine artery ligation was done. Hemorrhage continued, and that is why we did an internal iliac ligation. After confirming hemostasis, we closed the uterus and closed the abdomen. But when we did the vaginal toilet, there was profuse vaginal bleeding. So the patient was reopened and an obstetric hysterectomy was performed. So this is how it can lead to a placenta accreta spectrum can lead to so much of a hassle. But it is the importance of being prepared, and and to prepare the patients for some eventuality was important, because the patients and relatives were prepared for a complicated surgery. They were geared up to arrange for blood. They gave consent for hysterectomy since they were made aware that such an eventuality can occur in this case. So that is how this case unfolded, and we were saved in the situation. And in contrast, we had this case, Mrs. AB presented at 28 weeks for registration for delivery. She was a gravida 4, para 2 abortion 1 with 2 previous LSCS, 7 years and 3 years back. The USG had reported, and with what the patient had got with her, with the report, placenta posterior wall. On sonography, I thought placenta was in the interior lower segment and extending to the posterior wall, and there was a suspicion of placenta accreta or query vasa previa. So incidentally, my radiologist had called me that, listen, if you have some images of vasa previa, send it to me. So I sent this particular image to him, and this is the sort of thing which he got back to me.
So this is the placental tissue along the anterior wall, and this is the placental tissue along the posterior wall, with the umbilical cord getting attached in between. This is the umbilical cord coming here and getting attached here, and there are these couple of blood vessels, fetal blood vessels, which are unprotected, running over the placental surface and within the membrane. So this is a potential vasa previa. How the distance is around 5 centimeter from the internal os. So technically it is within that range, but she is more susceptible to her placenta previa with marginal venous lakes than this. So anyways, you would be performing a C-section for this patient.
So the patient was registered at a tertiary hospital. This time I said, please go and register there, with facility of blood bank being over there and an ICU set up there. A sonography was repeated at 35 weeks to map the placenta, and the report said grade 4 placenta previa with suspicious placenta accreta spectrum associated with vasa previa and marginal cord insertion in the low-lying placenta. They recommended an MRI, but I don't know why, but we anyway got it done, and that also showed a defect in the lower segment. And LSES was done at 36 weeks. Patient came in labor. Male child 2.6 kgs, and for assisting anyway, we had called a senior surgeon in. At surgery, a small part of the placenta was adherent to the myometrium. It was removed. Hemostasis was achieved by a few ligatures of figure of 8 stitches, and the patient did well. So this is how, once you suspect a placenta accreta spectrum, you can be prepared for it and you can manage it well. Because when you have a planned cesarean section rate, a planned cesarean section in a case of a pass, antenatal suspicion, you have to confirm by imaging. you have a multidisciplinary team in place, with the obstetrician, anesthetists, etc., like we did. But if you are unplanned, you discover it intraoperatively, often in time when the hemorrhage is occurring. There's a situation of panic. There is no team coordination, and you ad hocly call for help. There is blood shortage or delay in getting the blood. The ICU is not pre-booked. Emergency hysterectomy is always under pressure. Whereas here, when you know it's a case of placenta accreta, you have blood cross-matched, you have an elective cesarean hysterectomy in a controlled setting. The blood loss to the woman is lost if it's a planned PAS case, whereas an unplanned case, always the blood loss is more, sometimes even up to 8 liters. The transfusion requirement is planned and there's minimal wastage. There is massive transfusion, obviously, and a high risk of DIC in cases which are unplanned. The incidences of maternal morbidity, like injury to the bladder and longer ICU stay, is much more in an unplanned case. And maternal mortality is less in an experienced center in a planned case, but it's quite high with in an unprepared setting with a case of PAS. So that is the importance of CAS, and even the neonatal outcome is much better if it's a planned cesarean done for a PAS. And of course, documentation is important. So that is a PAS case managed in panic is a catastrophe, but the same case managed in a plan is a success story. So that's how you should be having only success stories, hopefully, all of you. So basically, there are risk factors which raise our antenae. That is previous cesarean section, placenta previa, previous uterine surgery, cumulative risk with multiple scars, and history should raise a red flag. But many cases still go undiagnosed, and one is caught unawares at delivery. And it's not the hemorrhage that kills, but it's the lack of preparedness. So in ultrasound findings, you have this this acronym lacunae. L is for loss of clear zone of retroplacental area. A is abnormal lacunae, Swiss cheese appearance, grade 3 lacuna, large, irregular, are most predictive of PAS. Color Doppler hypervascularity, uterine bulge, no myometrium, and interior bladder wall invasion. They're all, the accuracy is 80 to 90%, and best diagnosed at 18 to 24 weeks by an expert sonologist. So just a diagnosis is possible. So whenever you have a case of placenta previa, uh, must tell your radiologist that he should rule out an accreta. What is the role of MRI? MRI is complementary but not mandatory for all. The indications would be posterior placenta, inconclusive sonography findings, or there is suspicion of deep invasion like a percreta into the bladder or parametrium or the side walls. That is when an MRI is required. And the signs, the dark intraplacental bands are often one of the most significant MRI findings. Like these are tabulated here, and would suggest accreta, increta, invasion, or percreta. That all would be told us by the MRI. So if necessary, yes, MRI is indicated. But when ultrasound has an average sensitivity of 90.7% and specificity of 96%, MRI overall sensitivity is 94% and specificity is 84%. But even if there is an absence of ultrasound findings, it does not preclude a diagnosis of placenta accreta spectrum. Thus, clinical risk factors remain equally important as predictors of placenta accreta spectrum as by ultrasound findings. So the structured approach for diagnosis and counseling is you first have a risk, then you have suspicion, you do imaging, and if it is proved, please plan a multidisciplinary surgery. The counseling, of course, is very important. You have to document the discussion which you have the patient, involve the family early, and the key messages are risk of hysterectomy and bleeding, timing of delivery, and dream preparedness. So explain the planned management to the patient. You'll have an obstetrician, anesthetist, urologist, maybe a blood bank specialist, and a neonatologist, all on standby. Delivery only in a tertiary care setup with blood and surgical backup. A planned cesarean hysterectomy with placenta left in situ is what is recommended. Do not attempt to manually remove the placenta. And the timing of delivery is almost 34 to 35 weeks. I'll show you the recommendations soon. After a steroid cover, you should counsel about the need of blood products, ICU care, and a consent for hysterectomy. Of course, you have to address the emotional and fertility concerns of the patient, because there'll be permanent loss of fertility. Discuss the psychological support and counseling. The partner and spouse is involved, of course, in it, and offer mental health support when required. Consent and documentation, of course, is very important, and optimize the pre-delivery preparation, like have almost 4 to 6 units of packed cells ready with FFP and platelets ready. Anesthesia has to be reviewed. And of course, cell saver can be used, or interventional radiology, if required, can be used, and the neonatal team is informed. So recommendations for delivery according to the ACOG guidelines, it is 34 to 35 plus 6 weeks. And most of them would say 34 to 36 weeks is the time when we deliver them. FIGO also says the same thing. And antenatal corticosteroids are given for lung maturity. And of course, you have to deliver earlier if there's antepartum bleeding, preterm labor, or a maternal compromise. So the surgery is basically a planned cesarean hysterectomy with placenta left in situ. For focal eccrita, sorry, like what we had, one can remove the placenta by manual extraction or surgically excising that area of the uterus and suturing it back, So there are figure-of-8 sutures, closed sutures, or resection of that part of uterine musculature has been reported. Internal iliac ligation, of course, can be done. But ultimately, hysterectomy is the mainstay, especially if the hemorrhage is too much. Do not delay the hysterectomy. Do a planned hysterectomy. But yes, uterine saving measures like this in focal eccrita can be tried. In the surgical trips, patients are frequently best served by placing in the dorsal lithotomy position to allow impromptu access to the vagina and bladder, as well as optimal surgical visualization of the pelvis. So when we are operating, we do not normally give a lithotomy position. We give a low lithotomy position, and the advantage is you don't have to tell your assistant to go and check the vaginal swabbing and lift up the covers and do that swabbing. If the patient is in the lithotomy, after you finish suturing, you want to just confirm how much bleeding is from the vagina. One can, just raise the curtain and somebody can do a swab from below and see whether there is bleeding from below or no. And of course, the skin, all other things are the surgeon, what the surgeon chooses, the skin incision, whether it's a vertical or it's a transverse one, the incision, and of course, this whether you do a cell saver technology or you do a radiological intervention is debatable, and it depends on which setup you're in. But prophylactic tranexamic acid is given at the time of delivery after cord clamping, may reduce the risk of hemorrhage with placenta eccrita. Dose should be 1 gram intravenous. A recombinant activated factor 7A has been used for the management of severe and refractory postpartum hemorrhage. So please remember that factor 7 is available now, and one can prepare and get for it. Occlusion of the internal iliac, radiologically preoperative placement of catheters or balloons for potential intervention is also controversial, because iliac artery occlusion has been reported to decrease blood clots in some, but not in all case series. And some studies have shown no benefit, but there could be serious complications such as atrial damage, occlusion, and infection, and that's why it is not routinely recommended. Now, when you have an unexpected or unplanned intraoperative patient where there is a placenta eccrita, then basically, if you have opened up the abdomen and the uterine appearance is like that, and there is no excruciating circumstances to immediate delivery, there are also recommendations that you should close up the case until surgical expertise arrives. But I doubt it in our clinical settings. If we will ever be doing that, we should be prepared for this and keep things ready. Once removal will not occur with usual maneuvers, then rapid uterine closure and proceeding with hysterectomy as judicially as possible should be considered. Placenta removal alone, followed by insertion of Bakri balloon, was successful in preventing hysterectomy in 84%, but only 19 patients, 16 patients kept the uterus intact in one of the studies, which was reported in 2018. So one can use pressure balloons, etc. But in general, when there is uncontrolled pelvic hemorrhage, hypogastric artery ligation, interventional radiology to embolize the hypogastric arteries, other methods to address severe and intractable pelvic hemorrhage include pelvic pressure by aortic compression or clamping. Aortic clamp is devised by Dr. Piley and it is available. Pelvic packing also can be done to stabilize the patient and save the patient life. The pack can be left in situ for 24 hours with the abdomen open and ventilatory support till the DIC comes back to normal. But it is all basically done in high big hospitals or tertiary centers. One can do these conservative management if patient lands up with a complication like that. Now let's talk about uterine preservation and expectant management. With expectant management, the cord is ligated near the placenta and the entire placenta is left in situ. Don't touch the placenta. It's going to bleed. So just leave it in situ. Data is limited to case series when evaluating expectant management. And in the largest series, which was of 167 patients, 22% of the patients required hysterectomy after an attempt at expectant management, whereas 78% did not require hysterectomy. I know of only one case, which I think Dr. Murari Nanavati had managed in his private, where he just left the placenta in situ, tied the cord, came out, closed the uterus, and waited for the placenta to just disintegrate. So in this case study, out of 36 patients who required hysterectomy, 18 were primary failures occurring within 24 hours of primary cesarean, and 18 were delayed failures. Means many of them, even after you close the abdomen and all, will require hysterectomy. Severe morbidity and death occurred in 6%. So it is not that it was all okay. There were even mortality reported in that case. Maternal sepsis occurred in 70% of the patients with severe morbidity, and those with successful expected management had a median time of to placental involution to 13.5 weeks. So it means it can take almost 13 to 14 weeks for the full placenta to degenerate. So does things like methotrexate or uterine devascularization help in these cases? So the techniques have included uterine devascularization with uterine artery balloon placement, embolization or ligation, and post-delivery methotrexate administration. In a large series of expected management of placenta accreta spectrum, there was one maternal death which was ascribed to severe methotrexate toxicity, which is surprising, and subsequent septic shock. So that is why, because the unproven benefit and possible harm, methotrexate to hasten placental reabsorption is not recommended. Hysteroscopic resection of the placental remnants has been proposed as an adjuvant treatment, but high intensity focused ultrasonography has also been used in conjunction with hysteroscopy. So we have these methods, but technically speaking, expectant management is dangerous and it has to be done very, very carefully. Now, the last point is how early can a PAS be diagnosed? As early as 11 to 14 weeks if the placenta implants on the cesarean section scar, and often presents as a cesarean scar pregnancy part of, and that CSP is a part of the PAS spectrum. The gestational sac implanted in the lower uterine segment or at the site of the prior scar, thin or absent myometrium between the sac and the bladder, placental lacuna, turbulent flow on color Doppler, bulging or irregular uterine contour, and abnormally low placentation after prior LSAS. So in early pregnancy, PAS is usually suspected as a cesarean scar pregnancy, which is considered as a part of the PAS spectrum. And what do you do? If you pick it up at 12 weeks, what do you do? It depends upon the type, depth, and the desire for continuation. So first is confirm the diagnosis by a transvaginal sonography and color Doppler. If uncertain, repeat a scan in 1 or 2 weeks to confirm the persistent invasion of the placenta. And over here, MRI can help. And counsel the patient extensively, because explain clearly that if she wishes to continue, she must be managed in a tertiary PAS center with surgical backup. The risk of massive hemorrhage, uterine rupture, and need for hysterectomy, and maternal mortality if the pregnancy is continued. So you have to put forward what all that patient has in store and then ask her whether she wants to continue or no. So basically, early counseling leads to safer outcomes. And if it's confirmed at 12 weeks, MTP may be probably safer than waiting for the full-term catastrophe to occur. But MTP also in such cases is not a routine procedure. It must be done in a center with surgical anesthesia and transfusion backup. You do an ultrasounded guided suction. You can use local methotrexate injection or laparoscopic or laparotomic removal, depending on what case it is. If the placenta is low-lying but not clearly invasive, then you can repeat a scan at 16 to 18 weeks, and many cases may migrate up or may show a different outcome. So be very careful when you pick up something like this, especially a cesarean section scar, which we see very often these days, and it's difficult, to follow up and manage these cases. So 3 golden rules: suspect early, the risk factor plus the scan, counsel early, the family must understand the risk, and they should be ready for all the plan of action, and plan delivery with a full team, blood, and the institute and the timing of the delivery. So thank you very much for this patient learning. That is the ACOG recommendations. They all clearly state all of this, what I have said in the lecture. Thank you very much for this opportunity.
Excellent presentation, and we got lot many things to learn from you, sir. We have also managed many cases over here, keeping the placenta inside, or even handling for like obstetric hysterectomies. But definitely, the whatever preparedness you told, that is very important, because if we suspect, we have to prepare. We should get prepared not only for blood but for other colleagues also, because in remote area like Palghar and different places, there are less number of doctors available, less number of facility available, inappropriate time is there. So colleagues are also important, and that's why what preparedness you told was really very helpful. Right? Any other chairperson wants to speak?
Dr. Rekha Tote, Dr. Nigudkar.
Nigudkar sir is not there today.
Rekha Tote is there.
Yes.
Yeah, it was a wonderful session. And thank you for organizing, and thank you for inviting me as a chairperson.
Yes. Thank you, madam.
Thank you.
Uday,
Thank you.
Can I share a personal experience?
Please,
Yeah,
sir, yes.
Hi.
Sir, just one word from my sir, just one word from
Yeah.
my side. That
Yeah.
blood preparedness is very important, and in remote area there is a very lack of blood. So we have been doing lots of work on blood donation and blood camps, and we have started with blood bank, and we prepare each and every patient. Like I am a gynecologist, but still I have started a blood bank, and I see to it that any gynecologist facing for blood, we take the blood in hand and we run for that. So this is what how we try to save the child in this area. Thank you, sir. Please go ahead, sir.
Yeah, I had a personal experience of 2 patients who were diagnosed as placenta accreta. One of them was even diagnosed with placenta percreta. And I got an MRI done in both of them. That is when I actually, devised the method of pre-cesarean delivery ligation of the internal iliac. After opening the abdomen, I harnessed both the internal iliacs and put a double strand of linen thread around it in case I have to do a obstetric hysterectomy in a jiffy. But you won't believe this, in spite of the MRI report saying the same, both the placenta came out like Amul butter. There was nothing. 2 MRIs I have done, Uday.
So Rajneesh,
Only two MRIs. I have stopped doing MRI after that. And it is a big center. I'm not talking about any center which is some altu-faltu center,
You are lucky.
It
So
happens.
count your blessings. And then it was contrast to me. Both the reports which I got from outside was okay, only placenta previa. Oh, nothing. And then when I saw, I said, no, there's definitely something wrong with this. So, you have to be very careful when you are judging the images. So
that's very true.
You can't just rely on one report. Maybe if you have a placenta previa, maybe send it to 2 radiologists and make it confirmed. Ke baba, accreta to nahi hai. That's all. Yeah, Ganpat?
Continuation of the same. Basically, last week I got a patient for second opinion. At around 14 weeks, they have the radiologist said it's a placenta accreta and you better go somewhere else. And then we got it done here at our place, and our placement's in the Ghatkopar area, and they say it's not there. So what I feel is along with the gynecologist, the radiologist also must be well trained in diagnosis in this. And as you said very well in your talk, I think in not necessarily all the time all placenta is fixed. It could be part of the placenta which is adherent, other part might be normal. The person which is seeing the part must have diagnosed another part which or something like this. So that's one of my opinion. Second thing is placenta accreta spectrum or syndrome. We always think of in a previous cesarean section or a scar, but it is not uncommon or unheard in the primaries also. So we have to keep sometimes these accidental findings. For example, high risk patients in the primaries, if there's a history of DNC done, history of ART, treatment taken for the infertility, basically any history of endometrial COX. And these are the patients which there can be a patient who is landed with the primary with the placenta accreta syndrome. And as far as my knowledge, I think at the moment Mahesh Gupta is doing too much of work. I have attended his workshop also, and they are doing a lot of conservative work after excision of that part of accreta after delivering the baby. Don't touch the placenta in that segment. They remove the full placenta along with that whole mass of myometrium and suture it. I think this is how the whole thing is changing. Just my few words. Thank you.
Dr. Uday, I wanted to know.
I agree with Dr. Ganpat, if I make a comment, and also about the radiological thing, it is not always true. Even I have got patients whom they have come with report of accreta, and when we make everything ready, and everything placenta comes out really nicely, at times, and at times even sometimes and scan which is done and it gets missed on a scan and it turns out to be a focal accreta. So we see a lot of cases which are being referred. So it is not usually कि you take it completely, you see the plates, the MRI plates. So what I have now made up my mind is I see those MRI plates myself, because sometimes the reporting varies, but if you see the plate, you can see the infiltration level. So when we see that plane absent of loss of plane and everything, then you know that yes, this patient needs a tertiary center management. So just the reporting, I think reporting is done by anybody. So we require a good reporting. So just make it a habit to see the plates. That is very important. And once it is diagnosed, yes, I think Dr. Uday has said it perfectly the way you do. Yes, there are cases where we try to remove the focal, and I have also tried in one of the cases. In fact, even I have left the non-bleeding part of a lobe of a placenta. Recently I had a patient. She was a 50-year-old IVF conception, and she was a primey. Okay, and that's what I'm saying. It is not, but she had a lateral metroplasty conceived after IUI, IVF, embryo transfer, and that patient came and she had a focal placenta accreta. We left that lobe of placenta. She was not bleeding, and later on patient passed that lobe. So she went home very well. She was a 50-year-old and really, and the baby also was a preterm section. So we don't know what was the outcome and everything. So I was little reluctant. Patient was stable. She responded to treatment very well and she went home. This is just 3 months ago.
Dr.
So
Uday, do
Thank
you
you.
feel
this is something which we need.
Thank you.
association?
Thank you, everyone. I can assure you, placenta accreta syndrome can go on till tomorrow morning, but we have a very action-packed panel coming up. So I think I will really like to request the moderators and panelists to start off the next session. So over to the MOC. Thank you so much, everyone, for those really visionary and wisdom-filled insights into placenta accreta, and wonderful talk by Dr. Uday Thanawala.
As
So
always.
we'll hand over to the
Thank you.
MOCs for the panel discussion.
सुप्रिया, तुझा
Thank you.
व्हिडिओ ब्लॅक अँड व्हाईट मधून कलर कसा झाला?
माझा सर मी कलरफुलच आहे, कधी ब्लॅक अँड व्हाईट नव्हतेच मी.
अमित.
Yes.
Okay, please continue.
Yeah, moving towards the third session, that is the panel discussion on a very important topic, that is difficult cesarean section, which we have day in and day out. So the moderators for panel are learned from the field of OBGYN, Dr. Pradnya Supe and Dr. Shreya Prabhu. Dr. Pradnya Supe is chairperson AMOGS Sexual Medicine Committee, and Dr. Shreya Prabhu is second joint secretary AMOGS 2628. Can we have their CVs, please?
Hi, I think we're running late. We can
Yeah,
continue
I
on the
think we can
series.
forget about the
It's okay,
series.
just introduce the panelists also, please, Dr. Rachna. I would be
Yeah.
very grateful. Let's
So
get
we
on.
have expert Dr. Komal Chauhan madam, who is known for her expertise in the field of OBGY. We have heard madam now. And we have stalwarts from the field of OBGY for this important panel, Dr. Preeti Vyas madam, chairperson of the Endometriosis Committee AMOGS, Dr. Ganpat Sawant sir, MOGS council member, Dr. Datta Panandikar sir, who is past president of the Thane OBGY Society, Dr. Rajendra Tiwari, secretary of the Palghar Society, Dr. Nupur Mittal, who is Secretary of the Thane OBGY Society, Dr. Vishwas Parolekar, Secretary of the Navi Mumbai OBGY Society, Dr. Rajneesh Patel, past President Thane Society, and Dr. Rahul Mahekar, Professor OBGY at Sion Hospital, Mumbai. So over to you, Shreya ma'am, for further proceedings.
Is my screen visible?
Yes,
ma'am.
Yes. So I think of the few names that Rachna mentioned, we have around 5 of our panelists amongst us. So before I begin, I want to thank one of our eminent panelists, Dr. Ganpat Sawant sir, because few cases that we have included have been sir's cases, and sir was kind enough to give us a few photographs and history as well. So thank you so much, sir. So let's start
thank you.
with the first case. So we all know that every cesarean birth is unnatural, and like Dr. Uday really mentioned and Parikshit sir also said, every delivery, whether it is a normal delivery or it is a cesarean birth, can always be eventful, and we can always expect a very different outcome that what we have pre-planned before starting a C-section. So let us directly go on to our first case. We have a primary patient, 28-year-old, 37 weeks, coming with active labor pains in the evening, progressed nicely as per the partogram, but her station was very high throughout. So, emergency LSCS was done with full cervical dilatation after waiting for 75 minutes with a high station. She delivered a male child, 2.6 kg, who cried immediately after birth. So, just to show, so Ganpat sir, I don't want you answering. So, because you know what the case is. So, this was the final result after suturing of the incision. Now, I would like to ask my other eminent panelists. So, Dr. Rachna, can you please mute yourself? Yeah. So, what does this picture really look like? Means what I'm really trying to ask is, what do you think has gone wrong?
Is it a unicornuate uterus?
No. So
It looks,
I feel
it looks very slim, like a size 8 uterus.
yes, sir is actually going in that direction. So I'll tell you, this was basically because it was a second stage section where the lower segment was extremely thinned out. The incision was actually taken at the vaginal end rather than the uterus, and baby was delivered through the vagina. So, so the term for this is basically laproileotrotomy, where you actually refer to delivery of baby through a vaginal incision during cesarean section. The uterus remains intact. There is very thin vaginal tissue, so they have a reduced amount of bleeding. And the disadvantage is being there's a risk of infection. And therefore, we don't know whether the scarred vagina might rupture or obstruct delivery in future labor. So what I want to really ask, let us begin with Dr. Nupur Mittal, madam. What are the other issues that we face while we are delivering such a patient where she has pushed, the lower segment is very thin? So what are the other main problematic issues that we face?
If the patient has undergone so much of delay in labor, then we expect more bleeding, more tissue. Tissue is very friable, and basically it can tear even while suturing once the baby is out. I would say excessive bleeding is a big problem in such a case.
Dr. Rajni sir, would you like to add anything?
What about the bladder? What happened to the bladder in that case?
I think Ganpat Sawant sir can tell us about it.
Ganpat sir.
It is
Bladder
his
Sir, this I'll tell you what, this is a typical presentation. It's not uncommon. What happens usually, this happens at night. patients are in labor. And why I said night? Because most of us are lethargic, even patient, doctor. So patient, unfortunately, they are in labor a really very long time. Now, when you say bladder, this is a primary patient. So when we open the abdomen, actually the lower uterine segment is really, really very well formed. Bladder is fantastically very well separated, very well dissected. With finger only, we can push it down nicely.
Yeah.
When you cut it down, it opened like a butter, no resistance, nothing. And the baby also came out smoothly. As Madam Nupur said, there was a bleeding, but there was no blood at all. It was less than the normal cesarean section. So why it happened? Because, and then I did not realize I have delivered baby vaginally. But when I was suturing the upper and lower uterine segment, I was thinking lower uterine segment dikh nahi raha hai, upper uterine segment is so thick.
Exactly.
And then what happened is my assistant was little alert and he said, I think, sir, हमने कुछ अलग किया है. And then we realized, oh my God. So this was an intraoperative diagnosis
Okay.
where the lower part we had cut in the fornix. It was so much that baby's head was actually vagina well effaced, cervix was only one. So we just couldn't differentiate between that.
Yeah.
So then,
So the cervix, sir.
so I had, cervix was intact.
Cervix was
Cervix
intact.
was totally intact.
Sometimes you can't
Anterior
even
fornix we had cut and the fully dilated, and baby was delivered through the anterior fornix. So that's why now I don't know whether this is called a cesarean section or vaginal delivery abdominally.
I don't know. Pradnya said some very big term which I've
Yes,
never
so
heard
sir
of.
has only found out that term and taught me that
So
term.
naturally we have to
But,
read, no? So that's that.
Rajneesh sir, in
Bol.
these cases, I think there are two main problems that we face.
I was coming to
One of
one
them
that is the
is
impaction
yes,
of the head.
impacted head. So, sir, should somebody who's doing a section like this for the first time, how do you really deal with the impacted head? If you can just tell us.
If they are doing the section for the first time, the best thing would be to tell an assistant to push the head from below.
Yes.
Okay. However, if you are experienced enough, like maybe Dr. Datta Palandikar or Dr. Ganpat Sawan, maybe they will be able to insinuate their hand very gently between the pubic symphysis and the head and try and reach the lower curvature of the head. But you have to be very gentle because I have landed up with suturing many lateral uterine tears, including the tears going into uterine artery, tears going down into the vagina, which are one of the most difficult ones that you can suture. So you can use Patwardhan's maneuver, modified Patwardhan maneuver, or because you said it is the first time, I would say that the best thing is to tell somebody to push from below.
From below.
But you should not push with 2 fingers, otherwise you will fracture the patient's the bachu's skull. You have to make at least 2 or 3 fingers ka cone bana ke tell them to push. That is the only caveat that I would like to say.
So, Dr. Datta Panandikar sir, the another problem that we face in such cesarean section is fine. Whatever method you use to deliver the impacted head, we are faced with the problem of the lower segment being extremely thin, and it is your sutures keep on tearing. There's a lot of bleeding. So, any points which you would like to place that we should take care of when we are dealing with such a type of thin lower segment?
Yeah, two, three things. See, the first thing is that when you do a cesarean for a second stage patient where the head has got stuck, even the bladder is advanced. It is very easy to even nick the bladder when you try to open the abdomen. So try to open the abdomen as close, open the peritoneum especially, as close to the umbilicus as you can. So you don't land up injuring the bladder, number one. Number two, you will realize that the bladder is almost at looking at you at the incision when you open up. Now, to avoid what accidentally happened to Dr. Ganpat is if you take the incision at the start of the UV fold, where the UV fold starts, if you take your incision there, then you will always land up delivering the baby through the uterus. Then it is less likely. But as Dr. Ganpat said, it was 2 a.m. in the morning, and either we are completely tired or we get up from sleep and we come, and this is a very rare case that has happened, and it is really nice of Dr. Ganpat to have diagnosed it and treated it. Now, regarding the impacted head, I have not yet ever asked an assistant to push the head from below. Probably my hands are thin enough that they go into any little cavity that I get to deliver the head out. I have, of course, used the Patvardhans, but I have always managed to somehow get the head out, even however badly impacted it is. So I think these are the two, three things which I would like to add, especially opening the abdomen. Opening the abdomen, I've had this once where I thought I was opening the peritoneum and actually landed up nicking the bladder because the bladder was very, very badly advanced.
So I think one more problem that we face in such situations is that the urine becomes blood stained, probably
Correct.
because of the pressure, because of increased dissection. So I would like to ask Dr. Preeti Vyas, madam, so what should be our really role when we find that even during section, the urine is really blood stained, or post-operatively we find that the urine is blood stained?
I think when we find that the urine is bloodstain intraoperative, while doing the closure itself, we need to be sure that we have not already damaged the bladder.
Our voice is echoing a little.
He has kept two devices on,
Devices are
Yeah,
No,
correct.
no, only one device is on.
laptop as well as mobile.
No, no, mobile is off.
Acha.
I'm not on the mobile.
Anyway, it's still echoing. Doesn't matter. Please carry on.
Please continue.
You are sounding beautiful. Go ahead.
Thank you. So I think the first thing is that make sure that the bladder is already not been nicked, as what Dr. Datta said, that while doing the surgery itself, you may have landed up damaging. Second is while delivering the baby, we do land up this thing, the bladder is edematous, it's stretched. So all that may happen. And these are the patients where post-operative also the bladder can go into a retention and into something like paralysis. So we do need to keep the catheter in for longer. Make sure that the urine output is monitored well and maintained well. If somebody has pushed the head up from down, then also at the end check that there are no tears in the vagina. A lot of times we'll end up having a tear in the vagina or in the posturphonics or in the foreshead because of the overzealous attempts at the vaginal edge. So I think these two, three things we need to keep in mind. And suppose we feel that the bladder has got nicked or got damaged, then not to worry. Keep the bladder aside, finish suturing the lower segment, and then go ahead and suture the bladder in layers.
Definitely. I think before we move on to the next case, I would like to ask our expert, Dr. Komal Chavan ma'am, if she would like to say anything about how do you deal with such a kind of section, in addition to whatever our other panelists have said.
Yeah, I think the discussion was very good, Pradnya. I think very apt case because this happens very much in our practice. What I would like to point out is that when we were talking about bladder. So what is happening, sometimes the patient is so fully dilated, it becomes even sometimes difficult to catheterize the patient or sometimes we can see that the bladder is full. And I have personally, the catheter did not go, and I was called in an emergency, a deeply impacted head, and the bladder was almost palpable and felt. But what we had to do is we had to disinfect the head, and it was not going it. We opened the abdomen very carefully above, and then after the delivery of, we would pass the catheter, but it was done with real expertise and care. But such situation also arises because sometimes you are not able to pass, so you require a very small size catheter. I think that is very required. If you have a very small pediatric catheter, you can try. The regular catheter did not go, it was in the middle of the night, then, and it was not very full, over distended. So I managed, I did the cesarean, delivered the head, and then catheterized the bladder, and then closed the incision. So we need to be prepared with such situations also.
Thank you.
Pratnya,
Yes, sir.
can I just small comment? Even though I'm
Yes,
not an
sir.
expert,
Please,
I'll
of
just
course.
say a
Sir,
few
you
words.
are all our
No, no,
experts,
Yes,
sir. Please.
Dr. Ganpat, always.
no, just see, not necessarily all the time hematuria means there's a bladder injury. Certain things I'll just tell you. When, like Datta said, when we want to deeply engage head, when we try to disengage the head from above, we forget everything and we apply the maximum force so that to take the head up. Now, in that feat, actually, there is extension, so many things, and sometimes bladder, which is distended for a long time, can give rise to subtle hemorrhage. Second is basically doyens used by the assistant. Every time we live, जोर से खींच. So that doyens also can give rise to hemorrhage. This is definitely is possible. And other things, yes, all of you have said that is correct. But these two things I just wanted to give you that can cause a hematuria.
I just want to add
But
one thing to
long
Dr. Tavan.
ingestion also can lead to hematuria, the blood tinting of the urine.
I have told all my staff to use only 5 cc inflation of the Foley's balloon, because most of the times you use 10 cc or more, 10 or 12 cc's is used, and that Foley's balloon gets trapped under the doyens, and it rubs across, even if you're not pulling very hard. So what I do is only put 5 cc's of balloon inflation, and if there is hematuria, run the IV fast, tell the anesthetist to give 1 cc of Lasix, 1 gram of tranexamic acid. By the time we finish and we are about to close the abdomen, we come to know whether there is any bladder injury or not.
Yes. Usually it is very transient because of the
It is very transient, yes.
and it goes. By the time you finish your surgery, you are much relieved. Your urine starts getting clearer in the catheter, so you can actually close it.
Yes, I think all our panelists have given us such valid take-home points for when you are faced with such a situation. We go on to our next case, Shreya.
Okay, for our next case, we have a little more difficult one now. So patient XYZ, she's 35-year-old and 38 weeks pregnant, second gravida with previous LSCL. Intraoperatively, we try opening the abdomen and we just could not reach, or rather reach intraperitoneal. So Pradnya, I think you'll have to keep changing the slides. So how do we proceed? So
you could not open the peritoneum at all.
Yeah, we are having intraperitoneal adhesions. The serosa of the uterus is completely adherent to the anterior abdominal wall.
In short, she is asking what are the different techniques or difficulties you will face while reaching the lower uterine segment.
Deliver the baby.
Sir, if we are not able to approach the peritoneal cavity, then we should try to go towards the upper part of the incision. Try to find a plane very close to the anterior abdominal wall to avoid any kind of bladder injury. That is what we are scared about, because we don't see anything and there is no delineation between the anterior uterine wall and the peritoneal and the abdominal wall. So bit by bit, we should try to dissect, find a window, and then, maybe things can be better, and try to open the uterus above all this, if possible. To just avoid the bladder, maybe even take a vertical incision or devise a J-shaped incision. Or
Can I add something here?
Yes, for people who are conversant with the extraperitoneal, many of them might go ahead and easily start with the extraperitoneal itself. And those are actually, even if you are not, you realize that as you start dissecting, you are inadvertently on the your lower uterine segment, and you get inwards. The bladder has been pushed down. You are not opened the peritoneum. You are still extraperitoneal, but the bladder has got pushed down. You are able to see the lower segment, and you deliver the baby through the lower segment, and then open the abdomen and do the rest. So while dissecting, inadvertently you land up doing an extraperitoneal cesarean section, and this has happened so many times. It must have happened so many times to all of us.
So now here you can see that the
inverted T.
No, can I interrupt here, Datta?
Yes.
What
Nandita.
about the previous LSCS incision? It will not affect the extraperitoneal approach?
Not at all. It doesn't, because it is very unlikely that the bladder is adherent to the previous incision. That doesn't happen. And usually when you try to push the bladder down and you are extraperitoneal, you will always be a few centimeters above the previous incision. So you never go that deep. So usually, and once you deliver the baby, you will always find a space to open the peritoneum and then do the needful. So
Okay.
many a times in the previous LHCS where it's difficult to open the peritoneum, you go ahead, start pushing the bladder down, you get little space on the lower uterine segment, incise, deliver the baby and do the rest.
You
Don't
just go a
waste
little,
time in trying to open the
yeah,
abdomen.
just go a little laterally, like they do for the
Correct.
laparoscopy. There's a lateral window in laparoscopic hysterectomy in previous cesarean sections. So what Dr. Datta is saying is just go a little more laterally and try and find a space there, and then dissect the bladder down, and you'll immediately get the lower segment.
Sometimes if I think if somebody is not very proficient with an extraperitoneal cesarean section, any alternative, I think we can go a little bit higher and try to go lateral to the, cut the muscle and try to reach laterally where the adhesions may be less.
Yeah.
Any experience on that? Ganpat Sawan, sir?
No.
All the people who have said is absolutely correct. So that picture again, please. So what Datta said, I'll clarify Datta's point first. Bladder is a dynamic organ. It fills and empties, and that's why below the cesarean section, usually it's a less adherent. Whereas cesarean section, there will be adhesions, and that's why in laparoscopic hysterectomy, you will see the scar is adherent, but once you bypass the scar, the bladder is quite okay. Coming to this case now, this patient, if you are shown and if you see carefully, this is uterus is plastered to anterior abdominal wall. It's a plastered. As Madam Nupur said, go higher up. So we have gone higher up. Unfortunately, I am not an expert. This is again my patient's case itself. So this is again what we are trying to gone up. We have reached the umbilicus. We are trying to find out the uterus from both the sides. And then we are cutting the uterus wherever it is attached to the anterior abdominal wall. In the bargain, what is happened, I can't show in the screen, but I was digging into the uterine wall, and that's why upper segment myometrium is incised vertically. That's been written on this slide. So then we realized if I cut it still deeper, I will do classical cesarean section. So we stop there only, and then we keep on saving the uterus, that's cutting the uterus between the anterior abdominal wall, that's peritoneum and uterus. And then finally, somehow, as Datta said, we have reached the lower uterine segment. So we have kept intact upper uterine segment with some part of myometrium dissected. We took a transverse incision, and that's the incision which is in lower segment, regular incision. Through that, the baby is being delivered. The bladder is being dissected perfectly, all right? There was no problem with the bladder. So what this case depicts is not all previous cesarean sections will have a delivery at the lower uterine segment, but it could be that upper uterine segment, which is so much plastered, will have such kind of these difficulties. So yeah.
So anyone has, I mean, there is this study that has been said that, every time hurrying from the time of spinal anesthesia to the delivery does not really matter to the baby, but sometimes being cautious and taking your time to deliver, seeing everything is all right, it's okay, the babies do fine. So we've not seen that if there is a time between the anesthesia and delivery is longer, there is any problem with the baby. Pranalija.
Next slide, Pragna, I think.
So, if somebody could answer that, can we predict and anticipate this earlier? Anything, any of these things, what can you go while entering the abdomen? Can this be predicted?
One of the things
Entering the abdomen.
Can I answer this one?
Yes, ma'am, please.
I think one of the things we see is there is a puckering of the anterior abdominal wall. Very clearly, we see something like that, And of course, the patient would give a history of a previous scissor or a previous surgery, which was followed by sometimes infection with prolonged hospitalization or fever or secondary suturing was done. So these are some points that we need to keep in mind. And what was the indication for the previous cesarean? Was it with a lot of prolonged labor at that time? Was there meconium? Was it done in a center where maybe the sepsis was not maintained well? Was it in an emergency? Was it a transfer patient to a tertiary care center and then a cesarean was done? So these are the times when you would keep a little this thing in mind, that yes, we may land up having trouble. Or if it was been multiple cesareans, then we would keep in mind that yes, we better be prepared mentally, that we may come up with some surprises inside.
Yes. Ma'am, just to add to, beautiful points that you have said, antenatally, we can anticipate these things. Just one more thing is when the patient has come to us in the first trimester, we can feel the uterus per abdomen. That is another thing that, in a very small early pregnancy, sometimes the uterus is felt per abdomen is
Pulled
another.
up. The cervix is also completely pulled up.
Yeah.
Yeah.
If you put in the
So one
speculum, you will see
question
the
which
cervix.
I have put, which I would like to ask people who have definitely done more than one or two cesarean sections in a one particular patient, what methods can we do in the first cesarean section that these type of adhesions can be prevented in the next cesarean section?
Yeah.
Any points about that, Datta sir, Rajneesh sir?
Meticulous closure of the intra-abdominal wall layer by layer. Some people I have
Sir,
seen
would you recommend that UV fold should also be sutured in a primigravida patient to
uh,
prevent
early in,
adhesions?
early in my practice, I used to. I have stopped doing it for the last 30 years, I think. I have not sutured the UV fold because I have started believing that it prevents the migration up of the bladder, if it is not actually sutured to the, and there is enough place available even if you have not sutured anything. And another thing I would like to say here is, although most of the surgeons, some of them, there is a hot debate going on whether the peritoneum should be closed or not, but I believe that the peritoneum should be closed. And the apex of your peritoneal incision, usually we incise the peritoneum vertically after we separate the recti. So that vertical incision ka absolute apex is sometimes, left behind unsutured. And that is where you will find, whenever you do a laparoscopy also, you will find there are adhesions there between the omentum and the anteroabdominal wall. So meticulous suturing is all I would suggest. There is nothing much else that you can do about it.
Sir, any particular way, or like peritoneum to be sutured separately, muscle to be sutured separately, or en-bloc suturing also helps?
No, I mean, my personal way of doing it is I suture the muscle and the peritoneum together and not locking. No locking sutures.
Okay.
The locking sutures are
Other
only
difference of
every third
opinion
or
we
fourth
have about this.
for the sheath. The locking should only be left for the sheath.
Komal ma'am, would you like to add something on this?
I think this is the most challenging thing, and we are seeing more such patients with plastered abdomen coming for cesarean section. And I think what I follow is the lateral approach, going high above, because the lower you go, you don't know what is below. Sometimes the bladder is just below your muscle, which is plastered. So going laterally, lifting the part of a bladder, sometimes you see that bladder ka one part is centrally adhered to the scar, the previous scar. So you need to reflect it. So the way laterally you go, you reflect it, it is better. You need to use lot of scissors and cut the muscle here, because that will be the knack to get space. Deliver the baby as early, that is what we all aim, and then you can do the rest of the dissection. So one should not waste time doing too much dissection extensively. Do as much you can safely deliver the baby through an incision, and then you can tackle other things.
Yeah,
Thank you.
your first question, Shreya, your first question, can we anticipate? So how we can anticipate is, once it's not pre-op but intra-op, once you dissect the rectus sheath away from the incision, what I do is I hold the rectus muscle with two helices close to the umbilicus. If I'm able to lift up the muscle well, that means there are no adhesions inside and I'll be 99% into the abdomen. Now, when I do this, if the muscle doesn't get lifted up, it means that the uterus is plastered. Then I'm mentally prepared that I would probably be doing a extraperitoneal cesarean. So that's one. And what Dr. Rajnik said is absolutely correct. Suturing of the parietal peritoneum is very, very important to prevent the uterus getting fixed to the anterior-abdominal wall. So I also do exactly what he said, the muscle and the peritoneum together in interrupted stitches.
I think that is such good advice from all our seniors. Okay, Shreya, shall we go to the next case? Shreya, you can take it, no problem.
Just one small, I will not take much time. ये भगवान ने चद्दर दिया है peritoneum. If you take it back and cover it, I think that should avoid the problems. And as Preeti said, infection, all those things. But apart from, nobody spoke about the suture material. If you have a suture material less irritant, it will be better. Now, could be this patient was used catgut in the previous surgery or some other material which is really irritant material and it gives a lot of irritation to the peritoneal structures. One. Second thing, I still believe in suturing the UV fold of peritoneum or at least getting them closer so that not raw areas face to the other structures. And lastly, that part of lower visceral peritoneum getting up. So what I do is I hitch it to the lower part of rectus sheath or just above the pubic symphysis. This was taught to us in residency that upper part of the bladder, we don't leave it hanging like that, but I'm talking about visceral peritoneum ka lower edge. We fix it to superior part of the pubic symphysis or at that part of the sheath so that above that level, the bladder doesn't come up in the next cesarean section. Thank you.
Okay, quickly moving to our next case. So we have a 32-year-old primey here. LSCS is being done for a floating head at 39 to 40 weeks and AFI of 20. Now, intraoperatively, while baby delivery, the head slips from the surgeon's hand and moves to the right side. So, how would you proceed?
So I think you shouldn't waste time looking for the head now because the head has, as you said, moved to the right. There will be probably a big gush of liquor also. So the best way is to go to the other side and try and grab the foot and deliver this baby by a bridge delivery, which should not be very difficult unless the baby is very big. It's a large baby, say a 4 kg plus baby. You may not be able to get the foot at all because it is absolutely at the fundus and you may not be able to rotate the baby at all, in which case then you are forced to do deliver by the modified Patwardhan method. But if the baby is not too big, then you will be able to put your hand and grasp the foot and deliver the baby by breech. I think that is what you have to do. Don't waste time trying to get the head down.
So now in these cases, if anyone else could take this question, now say this, we know that the AFI is 20. Anything to be done cautiously so that we don't land up with this situation?
Yeah, what you can do is make a smaller incision on the lower segment when you know that it's a hydramnios, and let all the liquor drain out. The baby is not going to suffer if it is without liquor for 3 seconds or 10 seconds or 15 seconds. So let all the liquor drain out and the head will automatically come to the lower segment. Then you enlarge the incision on the lower segment and take the head out.
Perfect.
No
Perfect.
question. No question of it going anywhere.
Any pair where giving a little head high to the patient or starting an antenatal low dose of oxytocin help in these cases, sir?
If you drain the liquor, the uterus contracts automatically.
No, sir, I'm talking about antenatally. Preeti ma'am, if you could answer that.
Oh.
Is ma'am there?
Are you saying that we drain the liquor antenatally?
Not drain.
No.
Not drain the liquor before taking the skin incision. Taking a bit of oxytocin, a very low dose of oxytocin before by the time you reach. Does it help, you think?
I usually do that where when I tell my anesthetist to keep the oxytocin ready, and when we are on the UV peritoneum, we tell the anesthetist to add it to the pint and let it go. And we literally shout that we are on the UV, so the anesthetist know to start. And typically first cut the lower segment without rupturing the membranes, then put a small nick in the membrane, let the liquor drain out slowly, don't be in a hurry to deliver this baby. Let the liquor drain out. That way the head also comes down. Chance of slipping the head is lesser. And also your risk of sudden gush, so sudden PPH and amniotic fluid embolism, all those risks tend to reduce. So yes, I mean, low dose oxytocin definitely also helps.
Thank you, ma'am. What any vacuum in these cases?
I usually do a vacuum in these cases. It's just easier, much easier.
Okay.
I think a lot of our friends do prefer to also use forceps because you just need to stabilize the head. I personally use vacuum.
So
in
use
the
a forceps,
cesarean.
single blade, double blade. Anybody who can shed some light on that?
Double blade
If-
only because the head is floating. If the single blade can be used only if the head is impacted or below the pubic brim, as a scoop or a shoe on.
What I do in these patients is, if the patient is not in labor, lower uterine segment is thick. Starting Pitocin is a good idea to stabilize the baby's head. But yes, taking a small nick and then putting suction on. Otherwise, actually, baby's both legs and our legs are in liquor, and the liquor is splashed all over actually. So then basically, once the flow of this thing is gone and lower uterine segment, believe me, it's quite thick. Our hands sometimes find it difficult to go. So if that, after extending the incision, I just put the vacuum cup there. Once I was sure the vacuum cup is applied from all the sides, no maternal tissue or anything else there, then we apply vacuum. And believe me, allow it to build it nicely. Let's not be in a hurry. And then along with fundal, give a traction, it really comes out smoothly. Otherwise, I find it's really difficult to take out the baby's head in very high floating heads.
Very true.
Yes.
Yeah.
Komal ma'am, if you would like to, Komal ma'am, is madam there?
Hello, yeah,
Unmute,
I'm there.
unmute.
I think everybody, I agree to what everybody has said because this situation you need to anticipate and be prepared and be ready because we can predict which patients because we know that the head is floating. So doing a smaller incision, draining the liquor, keeping a vacuum by ready, and I'm using vacuum routinely for such floating head if the liquor is like 20 and all. Even sometimes, non-engaged head and sometimes we do follow the same procedure. We allow the head to engage. Giving oxytocin, what you said, I have never tried starting it, but yes, as for the active management, yes, we keep it ready, but not for making the head engage, to stabilize the fetal head, but using instrumental delivery. And I think Dr. Parikshit spoke well about forceps also. So forceps, double blade, because you need to pull the head because it is gone above. And if at all you land up into situation, whatever your instinct says, the breach, whatever you get it, I think that is the best way to deliver the baby. But it should be quick. Your decision making has to be very quick.
Actually, if we have to look at find the legs, I think it is better than the
Pediatrician will start getting panicky, that they will say something has happened, the baby has rotated, and people start talking, So I think you have to be very quick at that time.
I think you have to be very calm also. That is
Yes,
one of, you have to be
because
very calm and react in that situation.
showing a lot of stress and tension there, standing waiting.
Well said.
So I think, yeah, I think we have one more case. If Dr. Rachna and Dr. Supriya feel that we have not overshooted, can we take one more case? But it is about placenta accreta.
Already.
Yeah, ma'am, we can take
We have
it,
done
but
half,
just we need
half
to
of it we
hurry
have
up.
done, so you can take it.
Yes, we can just
Yeah.
quickly see. So,
Yeah.
Shreya, I'll start.
Okay.
So we have a Gravida 2 para 1 living one with 38 weeks with previous LSCS. Antenatal ultrasound is normal. Placenta is anterior, shows no adherence. Intraoperatively, placenta is found to be adherent and it's bleeding profusely when trying to separate. So I think this is a common situation which many of us at a junior level, senior level have encountered. So we all know, I think Dr. Thanawala has had such a lovely
Beautiful
lecture.
lecture.
Yes. So just to ask, what should be done in such a situation? you feel the placenta is not separating, you've not really prepared for a placenta accreta situation. So what should be the first reaction that you should have, and how should you progress ahead? Datta sir, if you could just
Yeah. So now, as you said, this is something which was not diagnosed antenatally. You've gone in, you have delivered the baby, and you suddenly realize that the placenta is low lying and it's adherent. You are trying to separate the placenta and it's bleeding profusely. So it really depends upon how your expertise or skill is. If you are very good in doing an internal ileal ligation, you can try that and even secure both the uterines. But I feel in this case, if I was the gynecologist or the obstetrician handling this case, I would have taken a consent and gone ahead with an obstetric hysterectomy, because you are already, you have separated the placenta partially. It's bleeding profusely, as you have said. So I don't think anything else is going to really save this patient or from, all the morbidity and the blood transfusions, rather than doing a quick OH and stopping the bleeding. Of course, now
sir,
here you
any
have not taken a consent. Your consent is
yes.
not there for the OH, because you never thought that it will be a this. So maybe one of the assistants can go out, speak to the husband, let him know, take his consent, and go ahead with the procedure, because it's an emergency life saving procedure. So you can go ahead with the husband's consent.
I
Sir,
would go
any
one
role
step
of
further. I would go one step further and call the husband into the OT and show him how much bleeding is going on.
He'll fall down.
It doesn't matter.
No, he
But
has not
I'm
seen
sure
such kind of bleeding. He'll
any role
it
of
doesn't matter.
devascularization here, which we should trying to save the uterus?
Yes. Trying to save the uterus is only if she's a primey. Maybe you should try other stunts. If she has one child, if she's even a second para, end of the story, just remove the uterus, as Dr. Datta said. Because many a times patients have been lost only because the obstetrician tried to save the uterus.
Delay, correct. That's right.
That is the
I
issue.
think time to make a decision should be very quick.
Quick, yeah.
Yeah.
And Dr. Chauhan was saying earlier about blood. If you are suspecting anything, or even if you have booked the blood, many a times what I do is I tell one of the patient's relative to go and sit in the blood bank till I remove the child, so that although we have cross-matched and reserved the blood, person going from your hospital to the blood bank and coming back, that time is halved. कभी कभी फिर सिस्टर बोलती है अरे वो आदमी उधर ही बैठा, अरे मैं बोला उसको बुला वापस, you know. But it is always helpful because I also practice in Mumra, which doesn't have a blood bank. Till recently we did not have a blood bank. Now of course we have a blood bank and a storage facility. So in those days I used to tell the patient's relative to go and sit at the blood bank after having given him the blood, and they have cross match and everything. So that is another
Ganpat
point.
sir,
Yeah.
Ganpat sir,
Ka-
if you would like to share your thoughts about such situation, because sir also has a nursing home practice.
For this patient, actually, there's no point in thinking, because I will do best what I can do to save the patient's life. For example, we have already cut the placenta, try to save it's profusely bleeding. So I'll basically tie it so hard till I get hold of uterines. And as everybody said, I'll talk to all the relatives. Definitely, they'll take time to come out of that mental shock. But I will definitely go ahead with what I can do best. And today, I will go ahead with the hysterectomy, believe me. But I have done till date one or two like this. But giving, not giving too much of blood, we have saved the patient's life. Otherwise, if you delay it, then we keep on giving so many
Yeah.
blood, and patient goes in DIC and multiple things. So quick decision is really essential. Few points I have learned over a period of years is now to this, some of the gynecologists they do cesareans alone with the staff. So I think all cesareans we must have someone who is equally qualified. Doesn't matter, we might have to give assistance fee, but once in a while we might land up. But there are so many people who do, अरे उसमें क्या normal primary virgin abdomen Fatakat. But of late, I have started doing that. One expert assisted, because at this point, our brain stops working, and sometimes decision can be. So this is what I feel we must do it.
I think here I want to make a point. Even if you don't have anybody senior with you, I think calling for help at this situation is also one very key factor, because two minds always think better than one.
Mm.
Yes, Dr. Preeti ma'am, if you would want to add something.
Ma'am, a little different question, Pradna, if it's okay.
Yeah, sure, Shreya.
Same question, but ma'am, if this situation just comes as a surprise. See, if this situation we know antenatally, of course, number one, we're not going to deliver her in a nursing home. We are going to take her to a higher center. All the consents and all the explanations will be given prior. But what if you are expecting a placenta previa, you open and you suddenly see vascularity all over, that it may be an accreta? Then in such cases, what do you do?
The first thing you need to do is call for help. So anyway, when it was a placenta previa, which was known, we would definitely make sure that there is adequate blood transfusion and everything kept ready, and always keep one more person who is senior enough to handle emergencies with you as an assistant, because you don't want a junior who's struggling even to hold a doins to be assisting you for a case like this. So I think that is one thing that we need to do anyway when we are suspecting it to be a previa, forget being an accreta. And if there is a surprise on table, then you probably will have no choice but to go ahead with the surgery. I think gone are the days where you can close the abdomen again and then transfer the patient. I don't think that can be done. But first thing you need to do is call for help and immediately get your, the codes activated, where you definitely keep massive transfusion protocol ready. Tell the anesthetist also, get one more help if required, call for blood immediately. And once the baby is out, then you need to decide whether you need to tug on the placenta at all, or to let the placenta remain inside and somehow immediately go for an internal iliac ligation so that the bleeding comes under control.
The thought process in this is, um, after delivering the baby, to keep placenta inside or outside, I think that's little
That's a
debatable,
tricky
because
question. Yeah.
because some of the people I have seen, and I keep on seeing this name, Mahesh Gupta, they plan whether to be uterus to be conserved or uterus to be removed. So if you decide to conserve the uterus, then don't touch the placenta at all
At
before
all.
at all.
Yes.
Deliver the baby, and whatever the chunk of the tissue is there, the big chunk, they actually just take it out. In a live operative workshop, I have seen those people doing it, and very meticulous monitoring and dissection of the bladder, sharp dissection. Even if it's adherent, they push it down very high so that after delivery of the baby, they don't have difficulty in taking out that adherent placenta along with the myometrium. So they take a lot of time, and they do all these cases in spinal, so that they take a long time. In GA, you cannot take a long time for delivery of the baby. So spinal, open the abdomen, take sufficient time to push the bladder down, take incision above the site where the maximum vascularity, take out the baby. Once everything is fine, then without hurry, they mark it out that area of vascularity, placenta totally intact, take out the whole thing, and then suture it. I mean, they are done quite peacefully.
Or intra-op ultrasound also to demarcate where the placenta edges are so that they do not nick it.
Okay.
Yes, this has been. I think this was said in one of the CMEs. I'm not. I can't. I forget who said it. That they actually use the ultrasound interop to find out the uppermost limit of the placenta.
Yes.
So delivering the baby becomes much easier. You don't land up going through the placenta. So that is one of the things that some people do use. But I think what Dr. Ganpat said is this is really fantastic, that excising the whole chunk of the myometrium along with the placenta without separating it, as you said, with a meticulous dissection, pushing the bladder as low down as you can. And this will definitely prevent postpartum hemorrhage and maybe save most of the uteri.
Doctor, it's all very nice to do it, and I'm sure Mahesh is doing some work on that. But just remember, when there's a placenta accreta, the blood vessels between the bladder and the uterine wall are so terrible. You just try to push it down, and sometimes they bleed torrentially.
Bleeds, yes.
There's a lot of vascularity in the lower segment. The moment you try to incise the lower segment, it sometimes can bleed torrentially. So it's not a take-home message for everybody to try it. Placenta accreta spectrum, please be very careful. Go for don't remove the placenta, just deliver the baby and go for a hysterectomy. That is the treatment. But if you want to try, you have to make sure that the vessels, you can manage those. To push the bladder down is not easy. The vessels, you just try to even push the bladder down, the vessels, if they are ruptured, they bleed torrentially. So you have to be very careful with this. I'm sure Mahesh is doing in an area where once you've delivered the baby, and if you find, okay, only a restricted area is there, then you can go ahead with all this. But before delivery of the baby, I really would not agree with that very much.
I agree with Dr. Uday sir, because if you have an elective case which is planned placenta accreta, I think you everything is ready with you and then you can cry all that. But if you see on table something happens, you should not waste time doing all these procedures separating. Your decision making has to be very fast. So maybe for demonstration purpose, planned cases, stable cases, in a tertiary center with all backup, yes, but the message is that please don't try all this when you're alone or you don't have that expertise with you. It's always best to go ahead with hysterectomy and save the life of the patient.
You can judge yourself. The moment you open the lower segment, if it is too vascular, just forget about it. Just don't
It's
try to
always better
separate the
to stay
bladder.
away
And
from that placenta and have a high up incision, deliver the baby, and do a planned obstetric hysterectomy.
the woman's life is more important than any heroic things. There's no great need. You have to be very careful that bleeding should not be too much.
I think, Shreya, we can call it to an end.
Yes. Yeah. Thank you very much to all our esteemed panelists and our expert, Madam Dr. Komal Chauhan. Like everybody has come up with new things. I suppose medicine is evolving, and I hope we have newer things in which we are there and we can save more lives and be more useful to our patients. So thank you very much for all your insights into these topics. Thank you.
Thank you so much.
Yeah, thank you,
very
Pragna
much for the
and
session.
Shreya. It
Thank
was
you.
a fantastic panel. Good cases and good but something different from Dr. Ganpat.
Yes. Many interesting
thank you
cases.
so
I think
much.
very,
Thank you very
very
much.
Good
well
program today.
planned panel cases. I think very practical. They come every day and and it becomes a dilemma to all the doctors also when you have such emergencies. So very, very well thought of and nice pictures also, Dr. Ganpat.
थँक यू सुप्रिया सीझर करून आली बघ.
Yeah, difficult dialysis केला काय easy. That is a
फॉर
question.
हर एव्हरीथिंग इज इझी.
Everything by all of
No,
your
no,
grace, everything went
she heard
smoothly.
the panel, so it has become easy.
Yeah, I was hearing all instruction accordingly. I was operating.
But you know what? The more things you know, the more you get scared.
I
I
agree,
am
sir.
shit
Agree.
scared for any scissor when I start opening. अंदर क्या निकलेगा? अंदर क्या निकलेगा? अंदर क्या निकलेगा?
Sir,
सही है,
sir,
So
sir.
every case you should open as if it is your first case and let your mind do the job.
वो
Yeah.
नहीं
Sir,
हो रहा है ना
ज़्यादा सोचने
आजकल.
का
नहीं
नहीं,
हो.
Voltaire
ज़्यादा
has
सोचने का
said
नहीं.
one very beautiful sentence that knowledge is like a bubble suspended in space. The
हाँ,
bigger it becomes, the more it comes in contact with the unknown. It's a
Hmm.
very, very prophetically said.
And
yes.
the main
No,
worry
and
in Caesar is whether that uterus will contract or no after
Not,
delivery of the baby. That is the main tension. Until that
I know.
सर,
contraction happens, you
डॉक्टर
are very
उदय
worried.
सर, आप वहां तक रुके. मैं तो पेशेंट घर जाने तक. बिकॉज कभी
वो
1
तो
घंटे
है.
के बाद होता है, कभी 2
दोनों
घंटे के बाद
शांति से
होता
घर
है.
जाओ तब तक शांति
तो
अपनी.
तब तक नेक्स्ट डे कुछ अलग होता है.
Or
थर्ड डे पे
after
बेबी
that,
का
even
डिलीवरी.
the suture healing is one bigger tension. Will the sutures heal
everything,
properly?
Correct, correct,
There won't be
correct.
any infection. So I
Very
think that is
true.
the life of an obstetrician. It keeps
And
on
in case
full of
of our
stress.
patients, the variables are such great, their poor nutrition, but
Hmm.
not very healthy condition,
poor hygiene, everything is there to compound our problems. And end of the day, nothing else will get blamed. Only you will get blamed. That is how it is.
Any day. True. True.
So
But
No,
anyway,
no,
very
thank you. This
nice
would
and very
there is
stimulating
a
session. Thank you very much, all
there is a
panelists,
very
and of course
famous
हम तब तक ऐसे
the
बोलते थाम
even the
सुप्रिया.
moderators did an excellent job.
there is a very famous saying in English. When you start your career, no, ignorance is bliss. So as you get older, your ignorance goes away, and along with the ignorance, the bliss also goes away.
Very correct.
Very
So I think we
Thank
can
you, Supriya.
now wind up the session. Rachna, over to you for the vote of thanks. My
Thank you very
personal
much.
behalf, thanks to all of you, to all my esteemed, speakers, panelists, moderators, chairpersons, and of course my coordinators. They have worked hard very much. So thank you very much once again. And Rachna, if you can just propose the vote of thanks.
Thank you
Yeah,
so much.
surely,
It
ma'am.
was really wonderful discussion. Thank you all the panelists.
Thank you,
and
Supriya.
Rachna, over to you.
Thank
Yeah. Thank you, sir. So it was a wonderful panel with all crisp messages and very practical tips. Proposing a formal vote of thanks, we are thankful to respected Chief Guest Dr. Amay Purandare sir and who is President AMOGS, and Dr. Nandita Palshetkar ma'am for their gracious presence and encouraging words, and sir's vision for safe motherhood continue to guide us for this webinar series. Our sincere thanks to our guest of honors, Dr. Rishikesh Pai sir, Dr. Vinita Salvi madam, Dr. Sujata Darve madam, and Dr. Rohan Palshetkar sir for taking out time from their busy schedules and encouraging us with this academic feast. We are grateful to our speakers, Dr. Parikshit Tang sir for excellent update on forceps, Dr. Uday Thanawala sir for practical insights on PAS, and our expert, Dr. Komal Chauhan madam for demystifying difficult cesarean sections. We are very thankful to our chairpersons and panelists from Mumbai, Navi Mumbai, Thane, Palghar, and Sindhu Durg Nagari societies for their active participation and making this panel an interactive one and an insightful one. A special word of thanks to Dr. Pragnya Supe and Dr. Shreya Prabhu madam for excellently conducting this panel, and our sincere thanks to Corona Remedies for giving us this platform. And this is the third webinar in the series of Surakshit Matrutva Vyakhyanmala. My heartfelt gratitude to Dr. Supriya Arwari madam, Dr. Madan Kamble sir, and Dr. Prerna Krishnan madam for their teamwork. And we are finally thankful to our delegates who have joined us from Zone 1 and across this zone. Their enthusiasm is the real success for this series. So we continue working together for this Surakshit Matrutva webinar series. Thank you so much, everyone, for joining.
Thank you.
Thank you,
Thank
everyone.
Thank you,
you.
everyone.
Lovely Jodi,
Rajni sir,
Pragni
Datta
and
sir,
Shreya.
Ganpat sir, Preeti,
Thank you,
Shreya,
Supriya.
Rajendra Chavan is still waiting, Komal.
Where are
Nandita
you
ma'am is still
waiting?
logged in. What a phrase, so sweet of her. So thank you,
Hello.
everyone.
Thank you.
Pragna, thank you so much.
Thank you.
Thank
you.
you,
And
Rachna and
India
Mohan,
and
for
Shreya
behalf
the
giving
of
this
right people to
opportunity.
conduct this panel.
Thank you.
Thank you so much, madam.
Yeah.
So
Thank
on
you.
behalf
Bye-bye.
of Madan sir
Bye-bye.
and Prerna ma'am, we request you to kindly support them for their endure.
Yes,
Yes.
absolutely.
Thank you.
And Preeti.
Yeah, all the best for your elections.
क्या MLA का कि MP का इलेक्शन कौन सा है अभी?
अरे सर
नहीं,
आजकल
we
एमएलए
want our
एमपी के
people to
इलेक्शन
be
को
there,
इतना
not only in
इतना
MOGS and
एक्साइटमेंट नहीं
FOGS
रहता है
and
जितना चेयरपर्सन के इलेक्शन को रहता है.
नहीं 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 वही तो हमेशा रहता है. We want people to be there in state and center. ये तो हमेशा चालू ही रहेगा.
बराबर है.
Thank you. Bye. Good night.
Bye bye.
Bye-bye. Good
Everybody.
night. Good night. Good night.
Bye.
Thank you.
Thank you,
Nice
Corona
meeting you.
Remedies. We can stop the